Buenos días para todos. Un
My
saludo.
greetings
Muchas gracias
to all
por
of you. Thank you
webinar sobre
to
diagnóstico.
our
Vamos a dar inicio
and
Voy a
agenda. We will
darle la
start, and
palabra
I will pass the
al
floor
ministro
now
asesor
to our
regional del
regional
programa Enfermedades infecciosas
advisor
atendidas de la Organización
from
Panamericana de la Salud, la
PAHO,
doctora Ana
Dr. Ana
Lucianés, para
Lucianage,
que nos brinde
for
unas
her to
palabras
give
de
her words
introducción a este importante
as
evento.
an introduction
Doctora
to
Ana,
such an
muchas gracias.
important
Buenos
event.
días a todos y bienvenidos
Good
al
morning to all
webinario
of you. Welcome
sobre
to the
diagnóstico y
webinar
manejo de la
regarding
leprosis.
diagnosis
Antes
and
de nada, quería
management
decirles
of
que reciben
leprosy.
servicio de
Before
interpretación
anything, I
y
want to
pueden
mention we have
cambiar su
interpretation. You can
lengua
change
abajo o
your
arriba en su
language
pantalla.
on the
Tenemos
under
interpretación a español,
part
inglés,
of the
francés y
screen. We
portugués.
have interpretation to
¿De
Spanish,
acuerdo?
English, French,
Este es
and Portuguese.
un breve
So this is
recordatorio
a
para los
small
que no tenían conocimiento.
message for
Bueno,
all
de
of you.
nuevo, bienvenidos a
And once
todos.
again, welcome to all of you.
Es un placer
And it's a
estar aquí
great
con ustedes.
pleasure to be here
Como
with
saben, este
you.
webinar se
As you know, this
realiza en
webinar
alianza
is
con el
held in alliance
Instituto
with the
Lauro de
Institute of
Salvañón,
Lauders of
que es el centro colaborador de la
News,
OPS
that
y
is a
OMS
cooperator
para la
of
formación
PAHO
de personal en el abordaje de investigación
in the
de la
approach of
leprosis.
research of
Expresamos
leprosy.
nuestro
We will
agradecimiento a la doctora
start
Patricia
also
Samarcolosa, la
acknowledging
directora
Dr.
del centro
Patricia
colaborador,
Macolosa,
por su apoyo y
director of
coordinación de
this
este
lab.
evento.
With
Y
her
no solo vamos a
support, we're
contar
holding
hoy con
this
la
event, and also
participación
we will have the
de
participation
bien
of
destacados expertos
speakers,
en el
and we
campo de la lepra,
highlight
como es el
experts
doctor
in
Antonio
leprosy,
Barreto, el
Dr.
doctor
Antonio
Jorge Alfredo de
Barreto, Dr.
Almeida y
Jorge
la doctora
Almeida,
Estela
and
Nemi
Dr. Estela Nemi
Areilza.
Almeida.
Además, agradecemos a todos
And
los
also we thank all of the
participantes, invitados, al
participants,
equipo de la OPS
guests,
y a los
and
intérpretes,
PAHO
cuya
and
colaboración ha hecho posible
interpreters
este webinar.
with whom we
La lepra,
can
como
hold
saben, es una
this
enfermedad infecciosa
webinar.
crónica
Leprosy
causada
is
por
a
la bacteria
chronic
Mycobacterium leprae,
infectious
que afecta
disease that
principalmente a la
affects
piel y los
mainly
nervios
the
periféricos
skin
y si no se
and
trata puede causar
the
discapacidades
nerves. It
progresivas,
can
incluso
have
permanentes.
progression
En
and also other
2019,
problems.
la
In
Organización Panamericana de la Salud
2019,
lanzó la iniciativa de
we
eliminación,
launched
cuyo objetivo es acelerar la
initiative to
eliminación de más de 30
eliminate
enfermedades
in more
transmisibles
than
en el resto de las
30
Américas,
communicable
incluida la
diseases in the
lepra.
Americas,
Esta iniciativa está
including
alineada con la
leprosy.
Estrategia
This
Global de la
initiative is
OMS
aligned with global
2020-2030 y
WHO
busca interrumpir
strategy
la transmisión de la lepra
2020-2030
e
in the
eliminar la
transmission of
enfermedad.
leprosy and
En
eliminating the
2023,
disease.
la
In
región de las
2023, the
Américas
region of the Americas
reportó alrededor
it
de
reported
24.000
about
casos de lepra, más del
24,000
90% de
cases of
seleccionados de la región.
leprosy, and
Pero es
some in a
importante
single
destacar que hay
country.
un grupo
And
de países,
we have to
especialmente en
have some group
Centroamérica,
of
el
Central
Caribe, región del
America and
Caribe, así como
Caribbean
en
countries,
Sudamérica,
and
Chile
also
y
South
Uruguay,
American,
que
Chile,
tienen
Uruguay,
grandes
that
proyecciones de
have
alcanzar
great
los hitos de interrupción de la transmisión
projections
y
of
eliminación de la enfermedad antes de
interrupting the
2030.
disease and
Y bueno, y por eso
interrupting
estamos
this
aquí nosotros
disease
hoy
before 2030. That's why
para
we're here
poder
today in order
proveer
to
capacitación
be able
integral
to
sobre el
provide
diagnóstico,
capacity building
tratamiento y
about
manejo
the
de la enfermedad de
diagnosis,
progresiones,
management of
así como
the
estrategias para el
progressions,
monitoreo
and also
específico
strategies for
control
the
y la prevención
monitoring
de
and the
discapacidad,
prevention of
para
this
poder
pathology
diagnosticar
in
a
order to
tiempo
have
estos
a
casos y
early
tratar a tiempo
diagnosis
para
of
evitar
these
que
cases
sigan
and avoid
contagiando, ¿no?
the
Sigan
continuation of
ampliándose y podamos llegar a la eliminación,
its
la interrupción
increase
de su
and
transmisión y la
eliminating and
eliminación de
interrupting
la
its
propagación.
transmission of the
Bueno,
disease.
aquí tenemos hoy
So we
profesionales del
have
sector de
here
salud y
professional of the
autoridades
health
de toda
sector
la región.
and of the region.
Y como saben, vamos
And
a tener
as you
una
know,
duración,
we will
este
have
webinar va a tener una duración de
this
4
webinar
horas.
will take
Bueno,
about
esperemos
4 hours, and we hope
que
that
disfruten, que
you
aprendan
will learn
y bueno,
and
esto es
it,
un
that it will
poco
be fruitful
esas
to all of
primeras
you.
4
And
horas
these
para que
first
puedan
4 hours
reforzar estos
can
conocimientos
reinforce your
en tratamiento y
knowledge
diagnóstico, pero
in the
bueno, me quedaría
treatment and
aquí,
diagnosis.
seguiremos
And
apoyando
I will remain
financieramente,
here and will
como saben,
continue
estamos a disposición de todos ustedes.
here
Y
at
de
your
nuevo,
disposal.
bienvenido y
And once
muchas
again,
gracias
welcome and thank
por
you
la
very
asistencia.
much.
Adelante, Néstor.
Thank you very much to be here with us. Let's continue.
Muchas gracias.
Thank you very much. Thank you very much.
Ok, muchas gracias, doctora Ana, por las
Thank you
palabras
very
de introducción a
much,
este
Dr.
webinar.
Anna,
Solo
for
reiterar que
introduction words to
tenemos
this
interpretación
webinar. I would like
en
now to
inglés,
say once
francés,
again that we have
portugués y español.
interpretation
Ustedes pueden
in English,
cambiar
French,
el
Portuguese, and
seleccionar el
Spanish. You
idioma de su
can
preferencia
change your language
en la
as you
sección de
wish.
interpretación en su
And
pantalla
here
de Zoom.
in the
Por otra
interpretation
parte, vamos a iniciar
section
con
here
las
in the
conferencias
Zoom screen,
de
we
este
will
webinar
start with our
y les pedimos que utilicen,
conferences of
pueden
this
irlo
webinar,
haciendo
and we
mientras
request
transcurren las
for please
presentaciones.
use this, and you can
Utilicen la opción
use
de
this during the
preguntas y
presentations.
respuestas
You can
o en
have the
inglés
option of
Q&A
Q&A,
para
that is in
hacer sus
English,
preguntas
Q&A,
y Una
on the
vez
lower part of
finalice
your
cada una de
screen
las
to ask your
sesiones,
questions. As
aprovecharemos para
when the sessions are
preguntar a
ended, we
nuestros
will take
expertos
advantage to
sobre
be able to
las condiciones o las
ask
preguntas
questions
que
to the
ustedes están
experts
haciendo.
regarding the questions that
Voy
really you
a
would
continuación
like to ask.
darle
So
la
let's
palabra
continue now.
al doctor Jason
I will
Barreto,
pass the floor to
Instituto
Dr.
Neurolingüístico
Gaso
Alemán,
Barreto from
quien
the
amablemente va a
Souza Lima
presentar
Institute,
la primera
and
parte o
he
sección
will
de esta webinar
kindly
sobre
talk
un tema
about
trascendental para
a
nuestra región,
subject
que
that
es
is very important for
mejorar
our
las
region,
detección de
to
casos a través de
improve
un
the
diagnóstico
actions of detection
adecuado y
of the
efectivo de la
cases through
enfermedad.
a diagnosis
Doctor
that is
Jason, le doy la
compliant to
palabra y
the
puede usted
disease.
compartir
Dr.
su
Jason,
presentación. Muchas
I pass
gracias.
the floor to you for you to share your
Muito
presentation. Thank you
bom
very
dia a
much.
todos. É um prazer estar aqui e
Good morning to all
compartilhar
of
os
you. It's a pleasure
conhecimentos
to
que
be here
temos
and
enquanto
share
centro de
the knowledge that we
referência
have as a
para a
reference
América
center
Latina
for
para os
Latin
países da língua
America and for
portuguesa
the
e
Portuguese-speaking
hanseníase.
countries.
A Souza Lima é
And Souza Lima
centro de
is a center
disseminação de
of
conhecimentos, de pesquisa
disclosure of
clínica
knowledge and
e
clinical
de
research
tratamento e
and
assistência aos
treatment
pacientes
and
de
the Hepatitis disease, and also other
pós-graduação
dermatology
em
center. And we
dermatologia,
have
também além de
post-graduation
especializações
dermatology and
em
also
várias outras
expertise in
áreas
other
do
areas
conhecimento.
of
Então,
knowledge.
vamos começar a
So let's start
apresentação.
now with our presentation.
Então, vamos falar um pouquinho sobre
We
o
will speak about the
diagnóstico
diagnosis
da hanseníase
of
clínica e laboratorial.
hanseníase, clinical
Perfeito?
and
Todos
lab.
estão vendo? Tá tudo
Can
certo
you
agora?
see my screen now?
Perfeito.
No,
Não está
we
aparecendo?
can't.
No,
No.
no vemos.
Iniciar, compartilhar tela. Aqui, compartilhar.
I'm trying to
Agora
share it now.
Ahora sí, pero ok.
Yes,
Está
okay,
funcionando.
great.
Gracias, doctor Jason.
Great, it's working.
Ya
Thank
puede ver.
you.
Então, como funciona o programa
So,
de
how
controle de
does
hanseníase aqui em
control
nossos
over
países, né?
hanseníase
Aqui nós temos
in
o
our
governo
country?
federal que faz
We have the
as
federal
normas,
government that
nós
has
temos
the
o
guidelines.
programa de
We have
controle
a program of
diagnóstico
control of
e
diagnosis
terapêutica de
and
hanseníase. O estado
therapies of
monitora,
hanseníasis, and each
monitora o
state
que é feito em cada
monitors what is
município
done in each
e
municipality,
cabe aos
and
centros de
then
referência
it's the reference
coordenarem
center
e auxiliarem
is
os
responsible for the
municípios,
coordination and
tanto
helping the
no que diz
municipalities
respeito a
regarding
treinamento, a
capacity
laboratório,
building,
aos
lab,
hospitais.
and the
Cabe
hospitals
internar os
also
pacientes, sobretudo nos casos mais
can
complexos e casos
have the patients
de
in complex
reação, de
cases
intercorrência, tanto
and
da
also
doença
other
quanto da
problems
medicação,
regarding the
com os
medications
centros de
or drugs and
reabilitação
also the disease.
diminuírem, né,
And we
avaliarem as
have rehab
incapacidades e
centers to
corrigirem as incapacidades
correct
e a
any kind
comunidade,
of
né,
problems, and also
com
the
os
community together
centros
with the
de
centers
referência
of
nos
reference
municípios,
and the
fazerem toda a
municipalities
busca
have to
dos
try
contactuais. A
and
gente no
find
Brasil não
all
tem uma
the people involved. Here
centralização
in Brazil, we don't have a
do
centralization of this
tratamento, do
and the
diagnóstico
treatment
de
of the
hanseníase.
diagnosis of
Cada
hanseníase.
município, em princípio,
Hanseníasis.
faz o seu
Each
diagnóstico.
municipality has to
Houve
have their
atualmente
own
alguns estados com
diagnosis. Some
baixa carga,
states with a low
eles têm
burden,
menos
they have
referências, obviamente, né? Isso
less
é
references, of
decorrência
course,
da própria
regarding
condição. Menos porque
their
no
own
número de
conditions.
casos,
Lower
não
cases, of course,
necessariamente
not necessarily
o diagnóstico
the
será
diagnosis
descentralizado,
will be
né? Alguns
decentralized.
estados do sul
Sometimes the
tem um pouco mais de
southern
centralização, mas
states
em princípio a
have
medicação
more
é disponível em
centralization,
todo o
but
território
the
nacional,
medication
em
is
todos os
available in
seis
all the
mil
country
municípios,
with
solicitando onde é
more than
disponibilizado.
6,000
Como se
municipalities.
faz o diagnóstico
How
de
do we have a
hanseníase? Os
diagnosis
critérios
of
da Organização Mundial da Saúde
hanseníasis?
são bem claros nesse aspecto,
WHO is very clear with
através de uma
this.
área de
Through an
pele com
area of the
perda ou
skin with
diminuição
a
da
loss or
sensibilidade
decrease of
térmica,
stability
dolorosa ou
or
tátil, ou
tactile or
diminuição da
and
função autonômica, né? Ou
autonomic
seja,
function
redução
decrease,
da
that is the reduction
piloereção, da sudorese e
of
da vasodilatação
the
reflexiva.
dilatation or the
Então, isso já
vessels.
é critério,
And this is a
quando bem
criteria
localizado, já é
when it's
critério para
already
diagnóstico de
seen,
hanseníase
a
e
criteria for a
início
diagnosis of
do tratamento.
hanseníasis
O
and the
segundo
beginning of the
critério,
treatment. The
né,
second
também é
criteria
mundial,
also
é um
is
nervo
worldwide,
periférico
is a
engrossado,
peripheral
espessado,
nerve that is
endurecido,
thick, hard,
assimetricamente comprometido,
asymmetrically
porque a hanseníase é
committed
uma
with a loss, because
que é
hanseníasis is
múltipla, diferentemente das
a multiple,
polimiopatias, como diabetes,
like
coloríaco,
diabetes,
hipotiroidismo,
hypothyroidism and others,
no território desse
in
nervo deve haver
this
também
nerve, you
uma
should find
diminuição
also
ou
a
perda da
decrease or loss
sensibilidade
of
no território para que seja confirmada o
sensitivity
diagnóstico.
and
Então,
in
qualquer um
order
desses
to
dois
confirm its
aspectos
diagnosis.
teria
Any of
confirma o
these
diagnóstico. E o
findings will
terceiro e
confirm
último
the
critério é o
diagnosis. And the
critério
last one
laboratorial.
should be the
A
lab
presença
criteria,
de
the
bacilo
presence
ácido
of
resistente na pele
BAAR
compatível com
resistant to the
hanseníase ou a
skin, compatible
presença
with
de uma
hanseníasis,
biópsia
or
de
a
bacilo dentro de
biopsy
uma
of a
terminação
bacillum
nervosa
in a
ou de
nerve
uma
termination,
característica do
or
bacilo que é a
any
formação
kind
de
of
glândulos.
characteristics
Isso
of
também
this
confirma o
bacillus that
diagnóstico
confirms the
de
diagnosis
hanseníase.
also of
Tem que
hanseníasis.
salientar que não
We
precisa
have to
ter
highlight also
as
that it's not
três
necessary to have the
manifestações.
three
Qualquer uma delas já é
things that have been
diagnóstico
mentioned. Any
e
of them
já
is already a
autoriza em
reason
todo
to
o
have this
território
kind of
nacional
diagnosis,
o
and it
início
authorizes the
do
whole country
tratamento.
to start the treatment.
As classificações mais
The
utilizadas no
classifications that are
Brasil
used
são a
in Brazil
classificação
are
de Madrid, que é uma
from
classificação de
Madrid,
mais de meio
that is
século,
more
que se
than
baseia na
50
clínica
years.
e na
It's based on
baciloscopia. A baciloscopia,
bacilloscopy
quando
or
disponível e bem
in the clinic.
realizada,
When it's
é
well
útil,
held,
sobretudo,
it's very useful
para
mainly
diagnóstico nos
to
casos de
have
pacientes
a
com
diagnosis in
infiltrações
the case
difusas,
of
quando nem sempre
different
aparece uma lesão visível cutânea. Nos casos onde há
disease.
poucas lesões
When we
cutâneas,
have a
mas o
little
paciente possa já
lesions,
ter uma doença
but the
avançada,
patient
no
can
caso
have
de
an
hanseníase
advanced
amorfa, e também para aqueles
disease,
pacientes onde é
and also for
difícil
those
fazer o
patients where
diagnóstico
it's very
clínico.
difficult to
Na
have a clinical
classificação de Madrid,
diagnosis. In
utilizamos as
Madrid
4 formas
classification, we
clínicas,
use
a
the four
inicial ou
clinical: the
indeterminada,
initial,
a
the
dimorfa ou com
undetermined,
imunidade parcial,
morpher
a
with
tuberculoide ou
partial
de alta
immunity,
de evolução para
the one with evolution
espontânea, e a
of
bichoriana, que são os
spontaneous
pacientes difusos com
cure,
doença
and a
sistêmica.
diffuse one
Quando é
with
disponível a
systemic disease.
endoscopia, nós
When we
temos
have these
a
pathologies
classificação de
available, we have
Hickey e
the
Joplin.
classification of Hitley
Então,
and
a
Joplin.
classificação
They have a
inicial, a partir
classification
da
is
classificação de
initial one,
Madrid, com a
based on
histopatologia,
Madrid with
mais a
histopathology
imunologia e
and
mais os
immunology,
critérios de
and also
evolução.
the criteria of
Então, são
evolutions.
três
So we have
anos onde
3
foram avaliados, 62
years that
foram
we have
propostas,
6,
66 foram realizadas e
66
70
was
foi
review
realizada. É muito
immunology.
difícil mesmo
It's
no
very
Brasil
difficult,
ter
even in
uma
Brazil,
boa
to
qualidade
have
em
a good
hanseníase
quality
e
of
ter
its detection
uma
and to have
fácil disponibilidade.
an
São
easy
exames
availability.
relativamente caros.
They're
A
very expensive
classificação
exams.
da OMS de
In the
1997, por
WHO
esse
classification
motivo,
1997 for this region,
padronizou-se a
we
classificação para
standardized the classification
esquemas terapêuticos
to
paucibacilares e
therapeutical
multibacilares,
with
baseado no
the
número de lesões.
base of the number
É
of
claro
lesions.
que
Of course,
existem essas
we
possibilidades
have
de
these
pacientes com poucas
possibilities
lesões visíveis,
of
mas com
very little visible
doença mais
lesions, but
avançada, que
an
muitas vezes na
advanced
evolução
disease,
é
and
de
many
você
times in this
perceber,
evolution,
e
we
tem os
can notice
pacientes que não
that we
têm
have
lesões
some patients
visíveis,
that
mas
don't have
têm
any visible
uma
lesions,
lepra
but they
mais
have
difusa.
leprosy that
Então, a
is quite
baciloscopia
disseminated,
é
and
útil.
this bacterial
Então, em
copy is the
claro,
last one. Of
uma
course,
lesão de
a
hanseníase
lesion of
indeterminada é
hanseníase
diferente
that is
e,
undetermined
na
is
verdade, da
different
presença de um
from the
leproma.
presence
O leproma
of
indica que o indivíduo
leproma.
está com
Leproma
doença
indicates that the
disseminada.
person has
Uma
a
lesão macular
disseminated
indeterminada
lesion.
numa criança significa
Undetermined lesion in
provavelmente que a
children
doença está ainda
means
localizada.
the
Tem os casos
disease
de
is
lepra
still very
neural,
local.
que são
We have
raros,
a
mas
neural
eles existem, onde não há
leprosy that are very rare,
baciloscopia,
but they
nem
have,
na pele,
they exist, but we
e
don't
nem
find any
também na
lesion in
histopatologia
the
você não
skin, and
vê o
this
bacilo estar
topology, we don't
no
have
nervo,
any
e tem
finding,
os casos de
and the bacillus
hanseníase
is in the
difusa,
nerve.
né,
And
ou
we have a
hanseníase
disseminated
bichoriana polar,
hanseníasis,
onde também
where
as
we can also
manifestações
have
são sistêmicas,
manifestations that
muitas
are
vezes
systemic. Many times
diagnosticadas
the
equivocadamente,
diagnosis
como a
is
gente
wrongly
verá
done, as I
mais
will show
adiante.
you further
Então, os
on.
critérios de
So the
tratamento.
criteria for
A gente sabe
treatment,
que a
we
carga
know
bacilar
that the
é
bacillus
um dos
burden
critérios
is
que
one of
vai
the criteria that
influenciar
will influence
evolução do
in the
paciente.
evolution
Os
of the patient.
bichorianos, eles
The
são
Chevrons
virtualmente
are
alérgicos.
virtually
Os pacientes com
allergic.
morfotuberculoides, eles têm um grau de
Morphous
imunidade
tuberculosis
quase
have
igual, muito
immunity degree
semelhante aos pacientes
similar to the
tuberculosos. Então, eles
patients with
tendem a se curar
tuberculosis.
com
So
regimes
TB.
terapêuticos
So
mais
we
curtos.
have
Então, para fins de tratamento,
therapeutical
a gente
regions that are
sabe
shorter
que,
ones. For treatment, we
eventualmente,
know that
casos onde há
eventually cases where
uma
we have
resposta inadequada, tem que ser
an
pesquisada
inadequate
se
response, we had to
a
research
resistência
the
medicamentosa,
resistance
além da
to drugs
reinfecção
besides the reinfection
e outras
and
condições,
other
né, que o
conditions
paciente
the patient is not ready to have a good response. Wrong drugs or also therapeutical failure that rarely occurs with the polychemotherapy that is extremely effective treatment, safe. It can be used in all the number of patients, women, children, and kidney failure patients, and it's a very effective treatment. We have some problems like amorphous and sinuses, initial one. They have a very small burden of bacillus, and some are cured, shorter schemes, and others we could have other kind of treatments, and others eventually will need another kind of longer treatment. So multibacillar WHO standardized this kind of treatment in order not to undertreat the patients. Sometimes they have a single visible lesion, and during the treatment we notice that they have other subclinical lesions that are visible because of the reactions of the drug that show us subclinical disease. But the treatment MDGU is extremely effective and safe. The limitations of each classification depend a lot of the experience of the person in charge of availability. If you have a good light to check, to feel the peripheral nerves is also part of the diagnosis. We will show the nerves that have to be felt, and it's also important to highlight that Hanseníase is not a skin disease, it's a disease of the nerves, and because a lot of nerves under the skin, frequently we have skin manifestation, and depending on this, it's interesting to continue to lab exams. When we're not sure of the availability of the quality, it's preferable to use the number of lesions criteria. In the quality of the samples, we know that it's very complicated in many countries to have good quality of the samples, and frequently, even in Brazil, we have this, that we have bacilloscopy with a bad representation and quality, and it has a false negative result. The specificity and neurobacilloscopy is not an adequate exam. It has to become the ultrasound because the biopsy will not give a good result if you don't have a visible lesion in the skin, and also the possibility or not of a follow-up. And so the evolution of the patient many times shows we are not seeing a relative initial case. We were already more advanced, and this is something relatively frequent. The patient has one or two stains or a node, and during the treatment they have a reaction that is very severe, and we see that they didn't have an initial decrease.
Algorithmos que vão resolver a maior parte dos
algorithms that will solve most of the cases, but we have cases where you have to have references for the criteria for classification. So it goes according to the lesions, color. So the more chronicle it is, the less it is infiltrated in the skin, so that you have more defined contours, you will have loss of sensibility. When you have copper color lesions or more of a purplish color, it would be showing that you have less bacillus, but you will have more lesions. So the surface is very important as well, because it might be just a stain, a superficial papilla, so such as phenoma, and it could be also be just a plaque, and that it could be a central area of regression or not. So the more loss of sensibility or lesions, the more you have neurologic damage there, and usually for the nerve endings in the skin, you will find more bacillus bacillary lesions there. The number of lesions is important. Many lesions is one of those elements that we use to differentiate for the time of treatment and the evolution of this patient. And the nervous endings and the damage to it, so you have to assess how damaged they are, and if they are too critical, it can lead to sensitive or motor impairments. So the number of nerves that are being affected, so that kind of nerve, if it is sensitive or mixed, if you have a recovery of those patients with greater immunity, they tend to have higher amounts of damage to those nerves, and we have Hansen's in that that level of the skin. So they tend to have a less sensitive recovery because they what provokes the damage to the nerve is not the bacillary activity itself, but the immunological response when it is present within the nerve. So lab examination, back in the day we had Mitsuda, and now it's not worked for, it doesn't work for diagnosis anymore. And serology, we had that to assess the amount of virological damage. And then you have serology, which is very much in fashion now, but it's related to the bacillary activity. It's not that invasive, so it doesn't need incisions. Bacilloscopy, which is still a very interesting examination. It's easy to carry out in the field, so you can do that in any technical level of proficiency as with a nurse, and also histopathology, which is a bit more expensive and more complex. So the important thing is to correlate the clinical assessment with the histopathology or bacilloscopy, whatever examination you carry out. So it's important not to distance a diagnosis when it is clinical and well-based. It's based in history of physical examination and all that, but it's not necessary to usually carry out the other lab exams. And also the patient evolution is very important. So we have to accompany to check whether or not those lesions are coming back or if they are getting better. And whenever you have a worsening of those situations, you usually have an immunological reaction that the patient might have. So the patient might be destroying the skin itself. So speaking a little bit about the Mycobacterium leprae, it's the first bacteria that to be identified. It was identified in 1873 as the Hansen's disease bacteria. Before the lactosis bacteria, it grows very, very slowly, and every 14 days or so. It likes lower temperature than 35 degrees Celsius, and it affects the nervous endings of the skin and also the peripheral nervous branches. So more than 90% will have natural resistance to it. The effectivity is high, but it's pretty pathological. So it is transmitted with close communication. So the communication is with close contact and long-standing contact. So whenever you have a patient that has no diagnosis but has the disease, they can be a vector for that. So it is predominantly happening in the skin and also peripheral nerves. So the incubation period lasts over around 14 days. It's very long and asymptomatic. So usually the patient will only look for a doctor when they have a very advanced situation there. So that's why we usually highlight the contact examination, the touch examination, especially for people who are genetically related to the patient. So it's a very low degree of evolution, and it takes a long time. So this is the cellular wall of the bacteria, and this is the outer wall. It is the lipid part, and it's usually when you have vaccine there for Hansen's disease, you will have a bit more concentrated vaccine, and it is usually cold. It's different from tuberculosis because it's you had room temperature about 20 or 30 minutes thereabouts, and we differentiate that with a bit of alcohol diluted with acidity. And for tuberculosis we use 3%, and for Hansen's we dilute that acidic alcohol for 1%. when we have 3%, a part of that will be 1/4. It could be 70% alcohol, but it's important to dilute that in order to not dilute all of the toxin that is right next to the cell wall. So bacilloscopy is for Hansen's shouldn't be used with the same reactions and the same techniques for as you would use for a scar with. So toxin should be different, the technique is different, and also the alcohol is more diluted. For the outer layer of the skin, bacillus will penetrate and involve the nerve endings that are responsible for sensitivity and for protection. They are nervous fibers, and they are very thin, and they are responsible for us and for a feeling of heat, protection of skin, and pain. So below it, we will have some other nerve endings that are responsible for sweat and also dilation of nerve endings. And right below, we'll have nerve endings that are responsible for touching and feeling, and also sensitivity to objects. And they are heading towards the trunk of the nerve. So there you have the motor fibers. And usually Hansen's will be dealing first with the sensitivity and then the motor activity. Usually you won't see the motor activity being affected first. So first sensitivity will be compromised first. So usually the bacillus will be fit to a protein in the cell. The protein would be laminine, and that would be fitting in the bacillus, and they would be phagocytated into the cell, and they will multiply within the cell. And that is what damages the capacity of this cell to reproduce and to reproduce correctly. So if we have a deterioration of the function of that cell, and as a consequence, it will no longer transmit the nervous drive towards the neighboring cells. So 80% of the diagnosis will be clinical history and touch examination, physical examination. I have a feeling here, it's a bit, well, you have to carry out a neurological examination. So you have to examine the skin, touch it, where the bacillus like to lodge themselves. So in the face, the neck, and also for those nerves, as we will show that, and I think Jory will speak a bit more about that. The nerves should be touched and assessed, and their functions should be tested as well. Do that on daylight, it should be natural light, because sometimes when you see the skin, you can see just a very low level of discoloring on the skin, and depending on the light you use, if you don't have a window or available, you won't even see that. So bacilloscopy and or biopsy of the skin will not discard that diagnosis, so especially for neuro cases. And it's very important to be careful with patients that whenever they have Hansen's disease, whenever they have autoantibodies, and when they have cryoglobulins, whenever they have Hansen's, they can also have in excess. So they would produce some products of the mistaken for rheumatological diseases for many years. So if you have a history, or if you have a family member with Hansen's, you have to value the non-specific symptoms. So let's say nasal congestion, that might be one of them. Arthritis could also be very specific to that. Paresthetics should be considered as well, because the nerves might be compromised. Intolerance to heat or excessive sweat in hairy areas, so they wouldn't be able to sweat in compromised areas. So sometimes the patients, especially when they have higher levels of damage, they might sweat a lot in the more tight areas, such as the inner thighs and also underarms and all that. But that could be confused with circulatory problems, and dry eyes could also be the case because of the lack of production of tears, and they could be scratchy, and the skin might be dry out because of the elevated level of sweat, and the patients might have less sweat in some specific spots, and they could even have glandular problems as well for sweat glands. So reticular problems also happen with the skin, acrocyanosis, and also bubbles and ulcers that might appear, and the patient wouldn't be able to explain because they could be especially in the back of their hands and their lower arms, and places where the patient might have contact with other surfaces that might burn or stuff like that. And sometimes they won't even realize. Show up out of the blue. So what should we do about it? So we have to test the thermal sensibility first. The bacillus is actually taking action there. So the subepithelium nervous ending will be affected first. So that's when we test that, and then we test the tactile sensation. So once you have a compromised tactile sensation, usually you will have a pain and also other kinds of problems first. So what are the forms of Hansen's that I can consider to be polycybacillary? So usually that's the initial phase of the disease. Usually it happens 2 to 5 years after the infection, and usually that happens to kids and people who are actually recently in contact with the patient, which the patient has not been treated. So how does that manifest? Usually with stains, or just an area of the skin where you have a single area where you have alterations of the sensitivity, and also the reduction of sweat, and also the autonomous alteration of the skin. And if that patient shows a lesion, and if they have sensitivity problems, they will not be in this initial phase anymore. They will be in one of the posterior phases. So usually that is in an advanced stage. So it couldn't be positive bacilloscopy here. The patient is already evolving from the initial stage to a multibacillary form. So in this phase, even histopathology would be in a specific, not specific. So only 30% of the cases, when they have good histopathology, can confirm the diagnosis for polycybacillary Hansen's disease. So especially with kids, the diagnosis will be essentially clinical. So if the patient has a Hansen's diagnosis, it is initial, it is polycybacillary, and if they evolve to a reaction, or if they start a treatment and you have several lesions coming about their skin, and that patient is no longer in the initial stages, they will be considered to be in a more advanced stage. So we won't restart treatment. Thank God nowadays the WHO has not recommended anymore to have that restart of the treatment. Now we treat all of the cases with the same regimen, so we don't have to restart it. So we just go to a new year of treatment. So we have the immunological reaction, and then we have to decrease the amount of hypersensitivity so they don't have the reaction in the nerve. So here we have a kid with the macular lesion here in the skin, totally asymptomatic. No scratch, no burn, no pain. So no skin peeling off. In Brazil, we call that a alba epitheriasis, so white epitheriasis. So We see that in kids. We call that also white cloth. So usually when you have, 7-year-old, they would present that. When you see a case like that, you have to look for the family member that is sick and the mother. So sometimes the grandparents would be diagnosed because it's very common when for elderly circular numbness in their limbs wouldn't be noticed. Stain there, and then you will have that to test sensitivity to the skin. I will tube with cold water. This is a glass tube. This is an hemolysis tube, and another one with the warm. This is about. This is usually heat that I need to check if this patient is sensitive. So how can I calculate that temperature? So I use a test if the patient has sensitivity to that, usually for 2 seconds. If that's not tolerable, I wouldn't be using that in a patient. Usually you have a reflex to take that off, right, more immediately. So when it's cold, in normal condition, we will regularly perceive the difference in the check for the temperature there. They should be cold to feel that 20 degrees, the cold water, that would be usually in the fridge first for a couple of minutes, and then the warm water would be with warm water. You can use coffee. For you to use cold water and hot water, or newly recently brewed coffee. Sensitivity that you can check with for pain. You will use a needle, an insulin needle. Of course, that's a new needle, and no perforation, just touching, so that you can see whether or not they will feel that, and then you have to discriminate. You have to use different surfaces there. With a single instrument, you can have 3 assessments for sensitivity based only in the methodology. What can I do here? When can I do that? Within the leisure and outside. So you can have a check between the affected area and a normal skin. That would be my standard for comparison, right? That would be my baseline, so to speak. So if I don't have that, I can also try with cotton or dry cotton and then wet cotton, just to check if they feel that difference. And remember, you won't check for sensitivity for pain with the cotton. Of course, you will only check for the tactile sensitivity.
Eventualmente, quando tem uma dificuldade de compreensão, aqui tem uma mancha.
Many times when you have a lack of understanding, here we have a patient that had a normal skin, and you can have the stamina test. What is it? It's when you have patients, you have rashes, and you have a prick test. Dr. Jason.
Solo un mensaje, quizás no puede ver el mensaje de nuestros intérpretes.
You cannot see the message of our interpreters. They request us to speak slowly, please, because it seems that you're speaking too fast, and they request you kindly, please, to speak a little bit slower. Okay, the test of histamine can be done with a drop of 100 or 1,000 graduation and of histamine drop on the skin, and then they have a cutaneous scarring, and you will find a kind of a lesion, a local lesion. Then you have a reflection lesion that indicates the integrity of the nerve endings of that place, that's damage in Hansen, and also the urtica papula. In the Hansen lesions, the histamine test, you see this lesion that is inside, it's not inside the macula, it's inside the hypochronic maculas. It's very difficult to have a response, or there's not a reliability of the response. The people that have some kind of disabilities, any kind of mental disabilities, they have this kind of in basic health units. It's only to be done if there's only the assessment of the sensitivity to check the results. Here in the biopsy, normally in histopathology, you don't have any histopathological finding in most of the cases. So even in a reference and ending the vet surrounding it, but it's not sufficient to come to the cases like as the biopsy goes deep in nerve, in the glands here represented the in the nerve penetrating problem in the nerve. This selective attack on the nerve, you only find this nerve because there's no other that only has this again. This is very rarefying in a histopathological finding. And also, you find bacillus here, not having kind of, but it's already with a parasite inside a nerve or not. But also is a junction, and it's hypochronic. This is we have to highlight that this is very rare. Normally, it's a finding of exams. You check the lesion in the arm or any part of the abrasion. So let's continue. This is a first card. The tuber that is another disease, and they become a plaque as a ring. Have of a child, small child. And it's very limited sensitiveness. Difference, but the other part is preserved. Eventually, you can have a commitment of be very thick. And sometimes with necrocal disease, the prognosis inability. If the blood is positive in this lesion, the patient is not a tuberculosis. Hansen, it's immunity that is 100% immunity. So these patients cannot be treated for less oscilloscopy in the lesion during the treatment will evolve with a reaction or neuritis. This patient is not patient has a Hansen amorphous one that was initially understood as false possible. But as initially the falciparular scheme of treatment, and of course, having a reaction, they have a reaction, and we treat the reaction with corticoids. So here, on the initial lesion, it's very well limited. It's a circular lesion with total loss of sensitiveness in the lesion and totally good of the lesion. It can have a leishmanioses or different kinds of rashes that have different reactions. Here, it could be also confused with angular granuloma. That is the first diagnosis that we will have. How do we separate this from a Hansen? The loss of sensitiveness. Even the histopathological is very similar. Syphilis also can have this kind of approach. Our mycoses also have a similar finding, but many times they start peeling off. So when it's Hansen, you check the sensitiveness, you try to touch the nerves to see if you have any diffusion. You have bacilloscopy of the lesion. Why? Because of the lesion, because many probably you won't find bacillus in the ear or other places. This bacilloscopy in the lesion has to be negative. If it's positive, it's not a tuberculosis Hansen. Eventually, you can have only the commitment of one nerve and also atrophy of the muscles. So many times you don't have a skin lesion, but you have necrosis of a nerve. And this also is a localized Hansen. And many times you have here a stain, but it's atrophic. That indicates that there was an inflammation process quite aggressive in this area, and with a nerve ending that is coming out of the lesion that is thicker. The disease is still localized in this area. It's a local disease. Now let's talk about multibacillar Hansen. This one is when I'm going more disseminated from the initial way of determining Hansen. After 5 or 10 years, this initial lesion disappeared, it's evolving with new lesions. Then I find what? Many and the criteria is bad delimited or if they're and partial partial loss of the one nerve and genes that are head and also muscles of the eyelids. If this is negative, this does not, but many times can be done badly interpreted because of the dyeing. If you have a disseminated one, you don't have to have bacilloscopy or biopsy. You won't change your therapy based bacilloscopy or biopsy. If it evolves with a reaction, it can have a severe reaction with fever and commitment of the sight, or it can have also a reaction on the lesions and the nerves. And this reaction, we'll talk about this afterwards. They have several types of reactions. We'll treat the reaction. And of course, we treat them with a multibacillar treatment. If they have reaction, they have amorphous Hansen or another type of Hansen. For example, this is a patient. You can see here that the skin is all permitted. Here are some areas that have hypochromia. The skin has a copper color of the skin. The white areas are not stains. The white places are the ending of the disease. Here, a lesion, circular, very similar with tuberculosis, but these are extensive lesions, multiple lesions with very badly defined borders. Here's a normal skin, and here are the lesions. Here's a patient with the face also with lesions and the neck. And these patients, this commitment of the lesion will set the bacillus in the lesions of the patient here and also other parts, because this patient is already a patient in the Bischoff stage. It's almost a Bischoff. Here with a very thickened nerve. You can see it on the surface. What does this normally patient complain about? They complain about numbness on the side of the leg or the feet. And when it's a higher commitment of the nerve, like this case here, they have a complaint of cramps, and probably this is a nerve. We cannot see very clearly here, but here another patient with many lesions, 1, 2, 3 lesions, very defined lesions, and hypochronic here and in the center with a total loss of sensitiveness. What are we going to suspect? Dimorphous Hansen. And here, these kind of lesions, like rashes, these can appear suddenly, not necessarily they're chronic ones. What do? We will feel the nerves, we're going to check the sensitiveness, and with all this, we can see a multibacillar Hansen. We don't have to have a bacilloscopy. If the patient is not able to refer, if there's loss of sensitiveness, then I will have the bacilloscopy of the lesions and also from the other points. This one, of course, Dr. Jorge will talk about this. A very thickened nerve. This is a diagnosis. There's no other disease that brings this kind of commitment to a surface nerve of the skin. This is a proof. If you have a patient with a nerve like this in the picture, with this thickness, of course, they will have a loss of sensitiveness also, and many times they can have a very, very severe pain. They can have a very, very severe pain, and we have to have a surgical decompression of the nerves besides the other therapy. So a thickened nerve, it's Hansen until it's proven the opposite. Another nerve, radial nerve, a side nerve of the arm, and the radial nerve of this thickness also brings the diagnosis of Hansen, even if you don't have any stains on the skin. If you don't have negative bacilloscopy, you have a neural Hansen, and they will have a decrease of sensitiveness in that region. Here also, again, the patients with a commitment of the nerve and commitment of this other nerve, a thickening of the nerve and air of the skin here, hypochronic one. So this is also Hansen. We hear other stains here. So this patient with dimorphous Hansen. Sometimes dimorphous Hansen is very acute, like an erythrodermy. They can lose the skin. They can also have edema of the superior limbs, like if it were cellulitis, and with a lot of pain in the nerves. This can also be diagnosed as a rheumatological disease. But you have to think about Hansen also. If it can be a reaction, and with lesions like this one, reminding the rashes, it can suddenly start. How do I know this is not rash? I will test the sensitiveness in the lesion and out of the lesion. Thermal, painful sensitiveness. I'm not able to have a correct response, and I'm going to have a bacilloscopy of the lesion to see if there's any reaction. Here, vitiligious, and they have these nerves on the fingers. It can be a compression of the nerves, but it can be a commitment of CO to T1 endings, but you have to research Hansen. If you have commitment of the sensitiveness and motricity of both last fingers of the hands, you have to think in Hansen. Okay, so you have to feel the nerves, and if they have a lot of testing, it will be Hansen. If you don't have experience, you will send it to a reference lab. The patients with Hansen in both nerves, you can see it's vitiligious and it's not a Hansen disease. Eventually, Hansen can happen with these kind of great stains and blisters also. This is very frequent after the person is from the 6 months again in treatment with MTU. But it can happen also as a first manifestation of disease. When I'm going to know it's Hansen, I test the sensibility and the sensitiveness in the normal area and the lesion. If there's a difference, yes, so it's a Hansen. What kind of Hansen? With many lesions, it's multibacillar one. With plaques, then it's a Hansen dimorphous.
Quando a lesão está muito vermelha, aparece de repente, isso é quadro reacional.
When it's too red, it's related to that. So if the patient doesn't have that, I will treat it, and I will treat that with corticoids. So the same thing goes when you have a sudden appearance of those lesions. So what is the differential diagnosis that I have to think here? Lupus or tumors or lymphomas. skin tuberculosis, sarcoidosis, and other several diagnoses. How can I clinically diagnose that this is actually Hansen's without any lab examination? So I have to test sensitivity in the normal area, and then I have to compare that with the affected area. So in those cases, we always have a huge variation between the sensibility of the affected skin and the regular non-affected skin. So of course, the patient should also have the skin of the hand and the foot tested, and sometimes even the motor ability of moving their eyes. So this is the hardest way of having to the multivascular Hansen's disease. So sometimes the patient will have more than 10 years of evolution of that disease, and sometimes 20, 30 years. So this is the hardest one to diagnose, the Vachovian. So they don't have any stains, they will have cyanosis in the extremities, they will have hypoanhidrosis, and they will have drying of skin in their legs and feet. So eventually you will also see nodules that won't have any pain. They will have ardolosis, which could be accompanied by nasal congestion, loss of sensitivity, total or partial, so it varies greatly. And you have several specific points of the nervous system that are affected. So bacilloscopy should be positive. If you have Mycobacterium Hansen's disease and patient, they should have a positive result. Otherwise, it will be wrong, right? So you should try again or have a reference or a biopsy that will show that it's something else. So here, you have a patient with no spots on their skin, so you have a peeling of the skin, you have the hair will no longer show and no longer grow. It's common to have also gynecomastia with that because you have a testicular damage to those patients. They will have a lower temperature, and then you have damage to the production of hormones in those patients, and it's usually normal to have azoospermia and also the reduction of the sexual drive. So these patients won't show stains on the skin, but this will be a positive case as well. So sometimes the patient will have dry skin, you have peeling on the skin, you have thickening of the nerves. It's very usual to see that. You have nodules in the hands and the feet, in the ankles and the knees, and they won't have pain in those nodules and no stain. So this is something I made on this is just a touch examination. You see that. So you put a finger there, you can see that. Well, one of the interpretation is not working. Can we check the Spanish interpretation?
Quiero saber si
we want to see whether or not the Spanish interpretation is working. It's working now.
Okay.
There you go. I apologize, Dr. Jason. Just go ahead. Another very usual thing in those patients that are not presenting any stains, it's a nasal obstruction. So you have a facial infiltration and also in the skin of their heads, because that's a warmer area. The lower the temperature, you have less damage there, but especially the face and the nasal region will have an obstruction, and then you have the destruction of the skin there. It's very common to see calluses and drier skin, and this is very common, and sometimes they won't even complain about that because it doesn't hurt, so they don't feel any pain. They won't complain. So whenever you have articular damage there, you will have the finger will be showing bumps like that, and sometimes the rheumatoid factor would be positive here. It's not rare to see those patients with no diagnosis. Sometimes they actually pass because they will treat other diseases, and sometimes they will spend the whole life dealing with other diseases and they don't have a diagnosis specifically for that. So we have to know that we have other ways of diagnosing diffuse Hansen's, because they would be showing those symptoms. So we have to have tests for the sensitivity of limbs and elbows, knees, and the buttocks, and also the palpebrae. So bacilloscopy will show that diagnosis. Here we have a case of a boy with several nodules. His mother has been treated 10 years before for Verschoven Hansen, so Verschoven leprosy. So that would be a dry skin here with nodules, painless nodules, that is. You have several of those, and bacilloscopy came out positive. So Hansen's had nodules there, and you would see nodules there, and they wouldn't present any pain, and that was quite an advanced case. So you have a patient here, and a very the ear has been destroyed. The hand was looking like rheumatoid problems. He had a radiologic and clinical arthritis, and that seems to be the case. You have the bone lesion there, needed they didn't actually realize that this patient had other problems there, and they hurt, but they get cuts and they don't see that.
Parece que perdimos la conexión con... Doctor Jason, perdimos la...
Deu?
Perdimos
We
la...
have lost you briefly there, doctor. You dropped out. Can you hear? Well, yes, now we can hear you.
No, su pantalla no la estamos viendo.
But we don't see your screen, though.
Apresentação. Ok. Estão me ouvindo?
Can you hear me?
Sí, escuchando, sí, escuchando.
Yes, we do hear you, but we can't see your presentation, though.
Sí, pero no presentación. Puede compartir.
Compartilhar. Aqui. Compartilhar.
Ahora, falta ponerlo en modo presentación.
Consegue ver?
Conseguimos.
There you go, yes.
Essas outras formas aqui vocês viram?
Can you see? Did you see this picture here of this patient?
Aquí nos quedamos justo. Acá nos quedamos.
Qual foi a última?
What was the last picture you have seen?
Esta fue la última.
This one. Yes.
Aqui outro caso de hanseníase vichoviana, com
So
face
this is another
couro cabeludo preservado, comprometimento nasal.
Case here with nose damage and also daclyocystitis, and also a problem with hand and feet and lesions that are drilling up into the nervous system there.
Bischoviana também pode aparecer com um quadro muito agudo, com quadro inflamatório, eventualmente com necrose e muito mal-estar
And here
geral.
you have usually necrosis in a very advanced stage, so you have leukocytosis and rheumatoid and also several megalia and other stains in their skin, so it's a very bad stage here. They have a nodule that might be the first manifestation, visible manifestation of the disease. So it would be nodules and stains and very painful lesions, and also they might even seem like leukemia. So these are reddish spots, they are painful, and necrotic areas as well, which we will call that leprolazarine Hansen. So this is advanced necrosis already. That might be Hansen. So this could be manifest in very few symptoms, or they might start with a very extremely grave situation. In Hansen's, the spectrum here, you have a lot of possibilities here. You have locations, specific locations for lesions, and even systemic or diffuse lesions. So most of the cases will have painful stains and thickening of the nerves. So for the reactions I'll mention later, but for the major amounts of bacillus there, you will have nodules that is extremely painful and systemic. So the patients that have the situation, which is the most of the patients which are in the middle of the spectrum here, they will have the type 1 reaction, which is treated usually with corticoids. So without treatment, the tuberculoid patients will cure themselves, so they will have a good result there. But most of the patients, when they have no treatment, they will evolve and they will worsen their situation up to the point where they have that Bischovian phase there. So when you treat the patient, they will improve their situation and you have reactions. So it's very frequent to see no symptoms at all in the beginning, and then you have immunological situations there because you have a bacteria there, and then you can see immunoreaction. So here you have Hansen's that are in kids. So you have a dimorph tuberculoid Hansen's spot there, and then you can see infiltration happening. This is from the time when you have xylem, where with no treatment, they would just stay there, and 5 years passed between both pictures there, and the stain will become an infiltrated plaque, and then it will no longer show, and then you have diffuse infiltration there. So this is the most advanced, the more advanced stage of that. So when you find that, it didn't really start like that in the first 5 years. So the patient would have a history that went undiagnosed, and you have to diagnose the father, and you have to examine the parents, the grandparents of this kid that surely would show you the source of that. So just to finish off this first part about the diagnosis here, we have the clinical diagnosis here. So what we have to do, well, it's very variable as a disease. It might be just a spot. It could be very many spots. You could show as if it were vitiligo, so it might seem like a mycosis, several hyperchronic lesions, several lesions that are foveolar in nature here. So might have diffuse infiltration. It might show as nodules, which are called liproma or Hansenoma. So for chemotherapy, you could see the regression of those lesions. So in the end, you will only see the hyperchromia there. So it works. It is still extremely effective and very safe. So it will be used for any patient. The reactions might happen, so you have to pay attention for those reactions. You have to have an eye open for that. So they should be treated as soon as they show up. Collection of material there. If you don't know, very quickly here you can perform an ischemia at this spot. You make an incision there. You collect material from deep within the incision. You put that in the dish. You wait for that to dry, and you fixate that in alcohol for 6 seconds. And then this is the result of the microscope. This looks like a normal ear, but that is a boy with Varchovian Hansen. So this looks okay, but you have some bacilloscopy that should be carried out there, because sometimes you won't see that with your eye, but you can see that with the microscope. Of course, when you have lesions, that would be much more positive, so you can see the positive case there. You always collect those from lesions, and then you complement that with the index points. The treatment for Hansen's, back in the day, we would do that for 2 years with fixed doses. You can see that usually with 12 doses you will have a cure there.
Como que eu vou saber quem precisa e quem não precisa? Eu tenho que mandar para uma referência, porque eu tenho que descartar a
know who needs and who doesn't need that. So you have to have the reference, and you have to check for reinfections, and you have to have the possibility of also checking the resistance to medication. So I had a patient once that didn't have a good response to treatment, and this is still in the very high levels of bacillar charge, and we had to invite the mother of this patient, and she also had Hansen's disease there, Varchovian Hansen's. So it's nothing if you treat the patient, but you don't treat the family members that are also in touch with that patient, because they will only temporarily have a treatment for that, and they will acquire that again, because with no therapy, you will be able to deal with that without treating the family members as well. And of course, this patient was not regressing to the lesions as before after a year, so we have collected the material there, and then you can see bacillus which were whole and also fragmented. So you would see by the end of 1 year of treatment, if the lesions are not regressing, that patient should be sent to a reference in order to check for the possibility of reinfection or resistance to medication.
Okay. Então, lembrar, laboratórios de histopatologia, muitos não sabem
the labs, some of the labs don't know what is the FARACO technique, which is used by histopathology in order to check for Hansen's. Sometimes they would use Zeal technique, but Zeal is only carried out in the scar blade, so or biopsy for tuberculosis skin. We usually don't use the same coloring for tuberculosis and Hansen's. So sometimes we won't collect bacilloscopy for the lesion, and sometimes you will have a false positive result or a false negative result rather. And sometimes you will find patients with tuberculosis. So, but it's very rare. So it is a correct decision by the part of the WHO in order to have a unique regimen for both treatments, because you might make a mistake and think that the patient has Hansen's, located Hansen's disease, because you might not have enough experience to differentiate, but over treatment you will see that the patient actually has a disease that has been disseminated, so you shouldn't restart treatment again. You can, thank God, you can just WHO in 2018 now has provided for 6 to 12 months of treatment plus the follow-up in the cases. So this is with a single regimen for the disease treatment. And this is the FARACO technique. FARACO has been described, this is a technique that has been described in the state of São Paulo, where we are now, by the lab technician José FARACO. He saw that the blades, the dishes, shouldn't be done with the same technique for Hansen's and tuberculosis. So, and then we had the fight in the United States. He described a change in the technique, and now it is known as FARACO fight technique. This is a technique that is very old now, and it's a modification of this technique.
Como é que se faz a biópsia? A biópsia sempre tem que ser feita com anestesia do local, porque nem sempre as lesões são
The biopsy has to be with local anesthesia. So you have to have material not less than 5 millimeters. It cannot be crushed. It cannot be put in the pure formal. So if you have to have a biopsy, you have to have a lab to know well about the Faraco Zio technique, and the formal cannot be pure and has to be done with a good quality material. And if you have to have a biopsy, you have to have a good conditions for it. If you are not sure about the quality of biopsy or the one that's going to do it, I recommend it not to follow this procedure. The same for bacilloscopy, okay? 5 or 10 ml of formal, 10%, and the histopathology of Hanseníase tuberculosis, dimorphic morpholus. You can see that the variation is quite huge in the histopathology from the tuberculosis to Bischoffer's. And here is 6 low burdens on bacillus, and here no bacillus. The bacillus burden changes a lot from one of it. You have serology also. Yes, but it's only good for multibacillar patients, not good for initial patients. And then we will talk about the reactions later on. Any kind of question?
Sí, señor. Hay muchas preguntas.
There are a lot of questions.
Entonces, por el tiempo,
Due
como
to the time,
bueno, son un grupo importante y
it's an
varios de ellos
important
tienen
group,
un nivel de
and many of them
complejidad
have
importante.
a lot of complexity.
Agradezco, Dr. Jason.
So I
Trataré de
thank you
ser lo
very
más
much,
breve
Dr.
como
Jason,
usted pueda.
and be very
Y
brief,
antes de
please,
pasar a las
when you
preguntas,
answer.
agradecer
Before
por
I ask the question,
su
thank you very much,
magnífica
Dr. Jason, for
presentación,
your wonderful
donde evidenció todos
presentation
los detalles
and all
relacionados
the
con la
illustration of all
enfermedad,
details
que claramente
related to
muestran
the
el
disease that
conocimiento
clearly
que tienen
show
sobre
the
este tema.
knowledge that you
Entonces, la
have
primera
about this
pregunta
disease. The first
es la
question
siguiente.
is the
No
following.
sé si comprendí
I don't
bien
know if I
en el
understood
caso
well
que
in
tenga
the
un
case
paciente
that we have
paucibacilar,
a paucibacillar
una
patient,
lepra tuberculoide, el
tuberculosis,
cual desarrolla una
leprosy
reacción,
that
debo
develop
pasar
a
un
reaction.
tratamiento
Should I
tipo
start
multivacilar, es decir,
multibacillar treatment?
completar
That
12
means
meses,
complete
es la
12
pregunta.
months? That's the question. Yes. Normally, tuberculosis, true leprosy that's quite rare, it doesn't have reactions. The one that has reactions, according to immunological and histopathological classification, is dimorpho tuberculosis leprosy or Bischovian. This is the dimorpho has immunity, partial immunity, so it's not able to cure with short periods of time of treatment. So in WHO, I think this was the main finding of the experts of WHO. They saw that it was you were wasting your time having treatment with monotherapies like it was in the past. Until 2018, we had Dapsona daily and once a month fixing. But there are a lot of mistakes in the classification. Many times it happens what she's asking. The patient has one lesion that you're seeing, but it has a disseminated disease that will become clinical once the bacillus start to be killed. So if you have many lesions in the patient and didn't disseminate the disease during the treatment, the polychemotherapy doesn't allow this. What happened is that a lesion, a subclinical lesion, because the hypersensitiveness, the fragmentation of the amorphous bacillus caused by the therapy brings immunological response that makes the subclinical lesions become clinical lesions. In fact, this patient already had a lot of lesions, but sometimes the expertise of the one that is watching is not able to see it, or the bacilloscopy, the representation of the material was very bad. The true tuberculoid doesn't have reaction, and the undetermined also doesn't have reactions. In order to have a reaction, you have to have a relatively good immunity, but a bacillar burden quite great. ones you don't have, not antigens. In the case of undetermined tuberculoid, you cannot have hypersensitiveness reactions. The hypersensitiveness shows a reasonable quantity of antigens.
Muy bien, muchas gracias, doctor.
Thank
Vamos a
you. Thank
pasar
you
a la
very
siguiente
much.
pregunta.
Let's go to the following question.
La- eh, em, los pacientes
The
con
patients
compromiso testicular y
with
ginecomastia,
testicle commitment,
¿qué otro fármaco
what
podemos
other
usar
kind
además
of
de la poliquimioterapia o
medication can we do
para mejorar el dolor
besides the
testicular
ones that we have
y
to
las
improve the pain of the testicles
São
and
duas
all
coisas
the
diferentes, tá?
discomfort? These
O
are two
tratamento
different
do
things. The
bacilo,
treatment of the
que é com
bacillus,
antibióticos,
that is
com
with
aporte de terapia,
antibiotics
para matar o bacilo.
to kill the
E as
bacillus.
reações
And the
imunológicas,
reactions
você
of
tem que
immunological
reduzir a
reactions,
sua
you have to reduce
intensidade
the
com
intensity
corticoides,
with corticoids.
né? A gente vai falar
We will
na
talk
sequência do manuseio
afterwards
das
about
reações,
the management of the
manuseio dos
reactions.
medicamentos e das
How do we
reações,
manage the
né? Que é a
medication and the
que é a próxima
reactions?
apresentação.
That is the next
Então,
presentation.
são coisas
So
distintas.
these are different
Eu tenho na
things.
hanseníase
I have
matar o bacilo,
in Hansen, we have to
impedir que o
kill the
sistema
bacillus and avoid that the immunological
lese os
system
nervos, os
will
olhos,
bring
o
a lesion to the
testículo, as
eyes, the
articulações
testicles, the
também.
nerves,
Com o quê?
or
Com
the
imunossupressores,
with
né?
immune
Então,
suppressors.
no Brasil, a gente
In
usa
Brazil, we
corticoides,
have
nós ainda
corticoids,
temos
but we have
acesso à talidomida, que no
access
caso
to
dele é perigoso,
thalidomida
com extremo rigor,
with
então assim,
extreme
não
strictness
deve
of
ser
control.
utilizado se você
It
não tiver
cannot be
certeza
used
do
if you're not
rigor,
sure
né,
of
do
the
controle da
strictness
talidomida,
of
tá?
the control of
Mas o
thalidomide.
corticoide ainda
But
é
the
o
corticoid
carro-chefe
still is a
nesses
flagship
processos de
of this
hipersensibilidade,
process of
que é a próxima
hypersensitiveness.
aula.
That is the next class.
Muchas gracias, doctor.
Thank you
La
very much,
siguiente
Doctor. The
pregunta,
following question,
esperemos sea totalmente clara porque usa varios conceptos y quizás
I
para
hope
la
it's a
interpretación puede
clear
ser un poco
question.
manual.
Let's see.
Los pacientes con
The
lepra
patients with
y factor reumatoide,
leprosy and
BRL y
rheumatoid
ACA y ANA positivos sin
and
enfermedad
positive acne
reumatoide,
without
¿cuál sería
rheumatoid
el
disease,
manejo?
which
¿Es
would be
clara
the
la duda?
management? Did
É
you
muito
understand the question?
frequente, essa é uma
It's
pergunta muito boa,
this is a very good
porque na
question because
hanseníase,
in
ela imita,
Hansen,
inclusive,
it
doenças
imitates
reumatológicas. O paciente
rheumatological
virchoviano,
diseases.
ele tem uma
Virchovian
imunidade
patient has
celular
a cell
granulomatosa virtualmente zero.
granulomatous
Então, ele
immunity is
produz
virtually
muitos
zero to
anticorpos
produce a lot
contra
of
vários
antibodies
componentes do
against
bacillus.
many components
Ele não
of the
consegue
bacillus
fazer uma resposta
because they don't
granulomatosa de
have a
fagocitose.
good
Então, ele produz
response.
anticorpo
So
contra o DNA,
have
contra o
antibodies
RNA, contra
against
partes da célula. Isso
DNA
imita
and
muito
other
as
parts of the
doenças
cells, and this
reumatológicas, tanto
imitates a lot of
clínicas
the
quanto
rheumatological diseases
laboratorialmente,
in
né?
the lab and
Então, é
clinically
muito
speaking. So
importante
it's
que
very
pense
important
sim no
to
diagnóstico
really
de
think about the
hanseníase
diagnosis of
virchoviana em
Bishop von
doenças
Hansen
reumatológicas. Como que eu vou
in
fazer a
rheumatological disease.
diferenciação?
How
A
can we find a difference?
baciloscopia,
The
né?
bacilloscopy
Tanto de uma baciloscopia
of
dos fregaços de
the
pele,
smear
quanto de uma
bacilloscopy of the
biópsia.
skin
Eu posso
or
fazer
a
um
biopsy
faraco de
also.
uma área de
I can
pele,
have a
lesão, de
faraco
uma
of a
lesão, e eu
lesion
vou encontrar
skin
o bacilo de
and
Hansen,
to
né?
find the Hansen bacillus,
Lembrar que nada
reminding
impede que o
that
paciente tenha as
nothing
duas
avoids
coisas,
that the patient
mas
have
mais
both has both
frequentemente
things,
o
but frequently
VDRL
the VDRL
é decorrente da
is a
própria
result
hanseníase e não de
of
uma
Hansen
coexistência de
and not of
sífilis
a
com hanseníase,
coexistence
né?
of
Normalmente,
syphilis
os
with
testes
Hansen.
não
The
específicos para
non-specific
sífilis,
tests for
eles dão em
syphilis
torno de
gave
40%
about
de
40%
reatividade
of
cruzada. O
reaction, cross reaction.
FTADS, os testes
FTADA,
específicos
the
treponêmicos,
specific
normalmente
tests,
são negativos. Os
normally are
testes
negative,
não
but
específicos é que são
non-specific
positivos.
tests are positive.
Gracias, doctor. La siguiente
Doctor,
pregunta,
following
¿cuál es el
question,
mejor lugar
which is
para
the
tomar
best
la
place
vaciloscopía?
to have a
Perdón, el
bacilloscopy?
mejor lugar para
The best
tomar la
place to
vaciloscopía
have
es el borde de la
bacilloscopy
lesión.
is in
Se a lesão
with the lesion.
tiver um
If the
borde
lesion
elevado,
has
você
a
escolhe
high
a
border,
lesão
you choose the
em uma
lesion
área de fácil acesso
of
e que ela tenha
easy
um borde
access
elevado.
that
Se
has
a lesão
a
for
higher lesion
cheia e não
border.
tiver
If it's a full
diferença
lesion and
nenhuma
doesn't have
no
any kind of
centro do
difference in the
borde,
center or the border, you can collect any part of the lesion. But once you have a higher border than the center, that's the place you have to collect the biopsy and bacilloscopy. And if I don't find any skin area, I go to the ears or elbows and the knees. Why? Because they're cold areas and of easy access. So we only collect these parts if we don't have visible lesions, or at least a lesion and the rest of these points that I said, ears, the elbows, or the knees.
Okay. La siguiente pregunta. ¿Se
Next question.
recomienda
Do
uso
you
de
recommend the
corticoides
use of
previo al
corticoids
tratamiento de la
previously to the treatment
lepromatosa
of
para evitar
lepromatosis
reacciones
in
en el
order to avoid
tratamiento?
reactions in the treatment? No, it's not necessary to start a therapy with corticoids because not all the patients will have reactions. Only half of the patients will have reactions. The other half, the polychemotherapy will destroy the bacillus and the patients won't have reactions of hypersensitiveness. We don't know exactly what makes some people have reactions, others not. We know that some conditions like infections or parasites, diabetes, or vaccines, and a great amount of immunity stimulus can increase the response to the bacillus and cause reactions. So we don't use corticoids or thalidomide to avoid reactions. No, we don't do this. We treat this when we have a reaction. Once we have a reaction, we try to find the cause of the reaction, the cause of the immunological decompression. There are a lot of reasons for this. We'll talk about this afterwards. And then we'll treat the cause, and normally the reaction starts to regress. But that's the trigger. So we have to deal with the trigger, and then we have to give, yes, of course, corticoids. But we have to find the reason of the reaction. We don't give any kind of thalidomide or corticoids if we don't know the reason of the reaction.
Ok, tenemos una pregunta escrita
We
en
have a
portugués.
question in Portuguese.
Portugués o intentar leerla de esa forma.
I'm going to
Porém,
try to read.
o anti-PGL1
The L1,
uma boa estratégia para
is it a good strategy to detect,
poder detectar
to be able to detect
de
contacts, risk contacts? Yes, the patients. When are you going to find a serology, positive serology in a patient of Hansen or contact with Hansen? When they were exposed to someone multibacillar, non-treated recently, or if he has a disease, a subclinical disease, or even a visual disease that you cannot see. So it's a replacement, let's say, of a bacilloscopy that would have this reason. It's easier to do a quick test, but it doesn't separate the data of the patient. Once they're positive, you have to know if what is happening was a contact or if the patient is really sick. Anyway, you have to have a clinical checking and evidently other lab tests. A positive serology, you will see if they have numbness, cramps, or itching. If they have a positive serology with this complaint, probably they have the disease, and then we have to research and we'll try and find the cardinal signs of Hansen. The skin that doesn't have sensitiveness, they have that. Of course, the diagnosis is ready. With or not, it's already confirmed. If they also have thickened nerves with loss of sensitiveness surrounding the nerves, is the second
da OMS
criteria
Hanseníase.
of
Então,
WHO
mesmo
for
sem
Hansen.
a
So
sorologia, a
even if
sorologia pode
it's
lhe ajudar a
serology,
saber quem
serology can
mais
help you to
uma
know
pessoa com
who
risco maior,
else
porque essa pessoa foi
has a greater
seguramente
risk
exposta
because this
e foi
person was
recente,
exposed
né, nos
surely
últimos
and it
6
was
meses,
recently in the
alguém
last
sem
6 months.
te
So
ajudaria para
it
tomar
would
um
help
cuidado
you
maior,
to
vamos dizer
take
assim.
a greater
Mas o
care,
fato de ela ser
but the fact
negativa
of being
não te
negative
autoriza
doesn't
não examinar essa pessoa,
it
porque ela
doesn't
pode ser negativa e ter uma hanseníase
authorize you
inicial.
not to examine the patient.
Bueno, tenemos varias
We have
preguntas
many other
sobre el
questions
tratamiento,
regarding the treatment,
pero tenemos una
but
sección
we have
específica
a
sobre
specific
tratamiento,
Sim,
pero
tratamento.
section for
las voy a
this.
mencionar,
I will
doctor
mention
Jason,
them,
porque
Dr.
quizás
Jason,
cuando esté
because
usted presentando el tema de
where you're
tratamiento
talking about the
pueda
treatment,
abordarlas de una,
you
de una
can
manera
talk
específica. Hay
about them
una,
specifically.
básicamente,
We
quizás
have
solo
one.
las voy a mencionar para
I'm
que
only
usted
going
las
to
tenga en
mention them for
mente.
you to remember
¿Cuánto
them after.
tiempo puede
How long
permanecer
can
positiva la baciloscopia después del
bacilloscopy
tratamiento?
can remain
La otra
positive after the
pregunta,
treatment? Another question.
el tratamiento con esquema
The
paucibasilar
treatment
solo se
with
da para lepra
bacillar treatment
tuberculoide,
is only for
pero
tuberculosis
la persona que
leprosy,
aquí
or the
dice,
person who
según
writes that,
entendió,
according
para la
to what I
lepra
understood,
borderline
for
tuberculoide
borderline
en adelante se
tubercular
debe dar un tratamiento de
leprosy,
12 meses. Esa es
should
la
we
otra
give a
pregunta de
treatment of 12
tratamiento.
months? That's another
Dice,
question regarding treatment.
otra pregunta de
And
tratamiento.
another
La
question of
lepra
the treatment,
tuberculoide en una
tuberculoid
lesión nerviosa
leprosy and a
debemos
nervous
tratar por
lesion
12 meses
to be
según
treated
nuevos
during
esquemas de
12
OMS y las
months regarding
clasificaremos como
WHO
tuberculoide o
schemes,
linfomatoide.
and we'd
No sé si
classify it
quizás
as
por las
tuberculoid
características que involucran un poco el
leprosy.
tema de
I don't know
diagnóstico y de
if because
clasificación,
everything has
las
been
puede
mentioned,
abordar estas tres
maybe you can talk
preguntas en
about
este
these three
momento
questions
y
now
luego con más
or
detalle, doctor.
with more
Eu acho que
details
a gente
later on.
primeiro
I think
deve
we can
falar
talk
da
first
terapêutica e do
about the
manuseio
therapy
das
and the
reações,
management of the
que
reactions.
isso, essa
And
parte que eu vou
this
falar,
part that I'm going to
automaticamente já
speak
vai tirar
automatically will
essas dúvidas,
bring
né?
a light to these
Então, na hora que
doubts.
a gente começar a
So
fazer,
once we
falar de
start
manuseio, de
talking about the
medicação,
management
de
and medication
reação e
and reactions
separação
and
de
separation
reação, do que é
of
uma
reactions,
reação, do
what is a
que é uma
reaction, what is
recidiva,
a
do que é uma
regression,
falência,
or is a
do que
failure,
é uma
what
provável
is a
reinfecção.
problem
Então, na hora
reinfection.
que a gente estiver
So
falando
once
do
we're
tratamento
talking about the
específico,
treatment
eu creio
specifically,
que aí a
I
gente já
believe that
consegue
we
responder
will be able to
praticamente
answer
todas essas perguntas
practically
aí
all
que
these
foram
questions
feitas.
here that were asked.
Ok, ya por el
Okay,
tiempo voy a
okay, due
dar
to the
paso
time,
a
I
la
will
última
pass
pregunta
the,
que
I will
podemos
ask the last
responder en
question
este momento.
that we can answer now,
Y porque ya veo que muchas
because
ya
I've seen
están
that
hablando de
many
preguntas de
are
tratamiento. Entonces,
asking
vamos
questions about treatment.
a esperar
So
un poco,
let's wait a little bit
aguardar un poco para la
and wait a
sección de
little bit
tratamiento.
for the treatment
Y esta es
section.
la última
And this
pregunta
is the
y
last
es,
question.
¿la lepra neural pura
Neural or
entraría en una forma
nervous leprosy,
lepramatosa?
pure one,
Es mi
would be a
pregunta.
lechromatosis
Para
form.
você ter uma
For you to
hanseníase
have
localizada,
a localized
você tem que ter
Hansen,
uma imunidade muito boa.
you have to have a
Uma
good
vez que
immunity.
você não tenha
Once
uma
you
imunidade
don't have
celular
a
boa, o
good cell
natural do bacilo é
immunity,
deixar as células do
then
nervo
the
e
natural way of the
disseminar,
bacillus to
ganhar a
leave the
corrente
nerve
sanguínea e ir para
and go
todos
to the
esses órgãos que eu
bloodstream
falei.
and go to the
Então, a
other
lepra
organs. So
neural
a
está na
neural
faixa
leprosy
tuberculoide. Tem que
is in
ter
the
uma imunidade
tuberculoid.
maior
You have to
para
have a greater
conseguir
immunity
conter o
in order to be able
bacilo
to
dentro do
contain the
nervo,
bacillus
né?
inside the
Então,
nerve.
formas
So
dimorfas,
ways, dimorphous
intermediárias,
or
dimorfa do
intermediary
Chauvriana ou do
ways, or
Chauvriana, vão botar o
Chauvrignoni,
bacilo apenas
they don't
dentro do
have
nervo.
the
O
bacillus
bacilo ele
only
ganhará a
inside the
corrente
nerve. The bacillus
sanguínea,
will go to the
o
blood
linfático, e ele vai
and the
por
lymph
vários outros
and will
órgãos. Então, a lepra
will
neural
attack other organs.
uma
The
forma
neural leprosy
de lepra, de
is a
hanseníase,
way of Hansen
com maior
with a
imunidade.
greater
Por isso que a
immunity. That's why
baciloscopia
the
normalmente ela
bacilloscopy
é
normally
negativa.
is
Você não
negative.
consegue,
You
sorologia
cannot,
normalmente é
serology
negativa,
also is
a
negative,
baciloscopia normalmente é
bacilloscopy
negativa,
is
e você
normally
fazendo a
negative,
biópsia de
and
pele,
having
a pele tem uma
a
grande
skin
quantidade
biopsy,
de
the skin
terminações
has a great
nervosas.
amount of
Se não tivesse
nervous reactions, and
imunidade
if you don't have
boa,
immunity,
teria
a good
bacilos
immunity,
nessas
they would
terminações
have
nervosas, porque é uma
bacillus
área
in
mais
these
fina do
nerve
que o
endings
nervo.
because it's a
Respondeu?
it's not it's
Muy bien,
colder
muchas gracias.
air
Por
than
basado en el tiempo,
the
tenemos
stem cell.
ahí
So now we have a lot of questions. So we will continue with the question. I thank you very much. And all the questions that refer to the treatment, be aware that we will have in the final section will be about treatment. Okay, so Dr. Jason, once again, great comments about your presentation. In fact, it has been very, very interesting, and we will continue with you with the treatment section. Now we pass the floor to the presentation regarding monitoring motor and sensitive functions and the capabilities, and our colleagues, Dr. Jorge Almeida, Estela Neme Almeida of Lourdes Souza Lima Institute will talk about this. So I pass the floor to them, and thank you very much. And please share your presentations.
Muito obrigado. Deixar com os meus colegas, então, Dr. Jorge, Dr. Estela.
Thank you. I will now pass on the floor to my colleagues here. Thank you so much.
Ah, tá. Tem que baixar aqui. Sobe um pouquinho a tela. Vamos ver se
vou subir aqui, então vou fechar as duas e vamos abrir aqui. A gente abre aqui.
Quero que você abra primeiro e deixa lá.
Então vamos aqui compartilhar. Vou fechar aqui. Deixa essa aqui, né? Deixa eu só ver aqui se vocês estão. Nestor, vocês conseguem ver a tela?
See the screen?
E tela cheia?
Can you see the full screen now?
Tá bom, então vamos deixar aqui com o Dr. Jorge, tá? Eu vou deixar o Jorge
we will leave that to Dr. Jorge. Thank you very much.
Bom dia a todos.
Good morning, everybody.
Eu me chamo Jorge Antônio de Almeida.
I am Jorge Antônio de Almeida. I'm a physiotherapist at the Lauro Souza Lima since 88 to 2013. I've been retired now, and I have experience in human anatomy, but my whole training throughout my career, I looked for centralizing and heading back to Hansen's disease. And this is what led me to become an anatomist, because actually, as a diagnosis for Hansen's disease, also based on the neurological conditions, I saw there are very deep reasons why I should specialize in this topic. So now I'm part of the program for specialization in Hansen's at the state of Mato Grosso, and I'm also a guest professor at the Lauro de Souza Lima Institute at the Electro-Neurodiagnosis Lab. So the topic that we are dealing with today is the neuro damage in Hansen's disease. And well, for the program that we have here for rehab in Hansen's disease, of course, we have to have a basic knowledge of neuroanatomy. And On the other hand, for the clinical diagnosis, it is important to have full knowledge, which is even more important for that on neuroanatomy. But when you talk about the rehab, surgery rehab for Hansen's, you have to have a very advanced knowledge in neuroanatomy in order to base your program for rehabilitation for surgery rehabilitation in a proper manner. So this is my view. This is my point of view from the job that I do here at the Sousa Lima Institute. So we are going to see this drawing again. This is a classic drawing, but we will show it under a neuroanatomic approach in order to base our knowledge here that will be shared in the follow-up. So actually, we will talk about the nerves that are related to Hansen's at the head, neck, and especially at the extremity. So upper limbs, we will deal with the ulnar, the median ulnar, and also the radial. And also on the lower limbs, we will have the posterior and anterior tibial nerves. And of course, when you speak about the school nerves, when we talk about Hansen's, you have two pairs of nerves that are directly implied there in the diagnosis and the treatment for Hansen's. So first is the intra-skull at the fifth and the seventh pair there. For the three, the triple nerve there, it's first year of anatomy school, you will see that this is one of the most complex nerves in the school, and it is formed by hundreds of dozens of branches and sub-branches, and it branches out in many directions. And you also have muscles for chewing that are related to this. So for Hansen's, we have to pay attention in the supraorbital and supracochlear nerves, because they will provide sensitivity to the frontal part of the forehead and the skin under the hair, and also the eyebrow. So you can see that the lesions here will be affecting this very territory that I'm mentioning now, where these nerves inhabit. So the second branch of the triple nerve there for Hansen's is the long ciliary nerve. So you have the nasociliary nerve there that is part of the lower part of the ophthalmos nerve. So this is the superior division. So this is plays the role of providing sensitivity to the cornea. So this is something we know, especially from the test when we check the sensitivity condition of the cornea. We use sometimes a piece of cord or a piece of cotton, and this is the slide where you can see the whole reflex happening there when you have the blink of the eye. So once you stimulate the cornea, this will bring information back to the intracephalic nerve, and then you have a synapses there with the motor branch of the nerve, and then you have blinking as a reflex, as part of a set of nerves that are in the face and also towards the brain, and that will be responding in the cornea there, where you have the motor response closing the Meibomian gland there. So this is this kind of action where when you do that, you have the tears forming, and you have the fifth and the seventh pair of the triple nerve there. So the tear is very important because it has it's important to fight bacteria and also to maintain the cornea clean. If without that lubrication, you also will have a dry cornea, and you'll have some ulceration damage happening there. If you don't have anything done about that, and if you don't detect that in time, the patient might go blind, and loss of vision is one of the main causes for loss of vision is the lack of tears, and that's usually due to Hansen's, when sometimes we don't detect that. Of course, nowadays, considering the amount of knowledge that we have about it and techniques, that is, and the preventive measures that we take, of course, you can preserve the vision there. And for the seventh pair, it starts in the encephalic tract there, and it is in the transition between the bulbous and the bridge between the nerves there. And it is important for Hansen's because it controls all of the movements of facial expression. It's also responsible for 2/3 of the tongue sensitivity, but for us, it is important because it is coming from the side of the head here, beneath the parotidal gland, and it goes towards the face, the front of the face there. And the frontal nerve and the zygomatic nerve is important for us, and sometimes it gets thicker here, and you can see that, and the buccal nerve as well. And the role of that is actually to produce the tears and to allow for the periorbicular muscle in the face will contract, right? So just like in many other muscles will be sphincterical, so they will actually produce when they close, when they contract, they will close that opening and they won't allow the secretion to flow out. So remember that paralysis of this muscle here will lead to functional alteration in the secretion of the eye, so the tears won't come out, and the movement of the palpebrae and also the position of the eye compared to the position of the nerve. So one of the most common causes here is the lesion of the secondary cornea, which we call the labiophytal there. This is a gap that might be unilateral, and sometimes you have bilateral gaps. For the neck, we will have the cervical plexus. You have this different surface here. They are superficial, of course, and deep, but here it's important to mention the great auricular nerve and also the magnus auricular nerve. So it goes towards the parotid and also the ear and also the posterior portion of the face. The magnum nerve when it is damaged by Hansen's, it's easy to see because it gets very thick, and it's very much used in biopsies when you have neck biopsies, especially. And what about the brachial plexus nerve there? You have the terminal nerves here because you have the axillar nerve and the muscle cutaneous nerve. Due to their disposition, they are naturally not damaged by Hansen. So we have usually the different levels of damage caused by the disease will go to the ulnar nerve and then the median nerve, and then occasionally you will see that in the radial nerve. So the ulnar nerve, it might be described in detail here, but because it's the most common for you to see when we have Hansen's affecting the nerve, so we should pay special attention to it. So it comes from its roots in the medial fascicula in the C7, C8, and T1. It doesn't show here in this drawing because it only goes towards the artery there. It doesn't have any branches in the arm. So you can only see that from the elbow down, so towards the forearm. So you have branching out, it branches out up to the hand there. And you should remember that the whole body of this nerve is also in the articular branch there. So we had a case here of Hansen's when this patient had a lesion in the articular branch of the ulnar elbow nerve. So the ulnar nerve will pass through the sulcus here, which is a very thin one in the bone, and then it goes 12 centimeters to the radial fascia, and it goes to the medium flex under the forearm that flexes the fingers for fourth and fifth fingers down. It will have the second branch out, which goes to the ulnar flexor muscle in the carpus. So basically that's right next to the flexors there, 15 centimeters or so, and then it gets the dorsal branch, and 13 centimeters down gets to the ventral branch, through a channel that is formed by a fascia from the forearm, and then it is channel that is called the biome channel, and it gets distributed in the surface branch to the fingers, and then the deep branch which will in muscles there. You have the abductor, the brevis, and the opponent's digital minimi. So this deep branch there will advance a little bit more towards the particle muscles for the fourth and fifth finger, and all of the four will be branching out. They are all being nerved by the branching out from the ulnar nerve. And it is very invasive because it's region and it goes to the abductor thumb muscle. And then it ends getting to the deep fascia of this muscle here towards the thumb, because the superficial gets to from there. So in this slide, you could see the whole, the classic region where you have distribution of sensitivity there. And that's classic. Towards the next few slides, we will deal with the variations of those innervations there. And I'll just show you, I just like to show this case here, and this is due to my anatomy and the Hansen's disease. To be very careful when you can, will allow you to see that you have the dorsal nerve here with X2 tell nerve from sometimes to have patients have a thicker nerve here, and sometimes it's not the nerve. Here is a review of basic anatomy, the ability of kids and older patients as well. So I'll just show you the channel here. You only see the ligament there, and that is the ligament that is the bone there. So you will see that would be due to the anatomic description. You would see the full atrophy of the nerve in the interosseous space, thickening of the nerve within, and that fingers, and that is due to the incapacity of the be in harmony with each other. And one of the tests that we can see to check whether you have an ulnar nerve lesion there is just to hold a sheet of paper, and then you abduct the thumb. But if they don't have the abductors working properly, they will actually fold the finger towards themselves. So here I can show you that this is a very interesting aspect of this. You can see an atrophy in the muscle is related to something that is very common, which is the stigma for Hansen's disease and for Hansen's disease. And sometimes you have the full atrophy of the first finger hair. Here you can see that in the thumb and the ulnar nerve, and you can see whenever they shake hands, when they greet someone, they can see that they are unable to move that finger normally. And that's one of the first things that you have to pay attention for when you have a patient with Hansen's. And what's the first thing that they want to do is to be able to shake a hand normally due to the stigma that they face towards the community usually. This was a very quick presentation just to show you and just to be to warn you towards the, about the value of knowing the neuroanatomy, and we have to know basic anatomy in order to work with those patients. But we have to remember that the ulnar nerve is responsible for the innervation of the muscle for this hand strength, so the grip strength. Usually our patients will depend on their hands to work, right? So they are usually manual laborers, and we can use that maximum of by Gandhi that if you don't work, you don't eat, right? So if you have a unilateral damage there, that's a problem. If it's bilateral, it's even worse. Than if you have a problem with lower limbs and the eyes, that individual will in generally have to have a full assistance throughout their lives. So the second nerve is the medial nerve, and this is the ulnar nerve. Just like the ulnar nerves, it won't branch out on the arm, right? It will go down towards the forearm, and then you will have divisions there by the elbow. And it is, I could put this slide here just to show that it is responsible for flexation and pronation of the fingers, right? So all of them have a common origin here in the medial region here. So whenever you have atrophy of the medium region of the arm, you can think about a high lesion there. But you have to remember that the same medial nerve has a path towards the thinner region of the hand, which is before it gets to the flexors there, it will be in the cutaneous palmar region, and also their branch that will be a very small compared to the distribution of sensitivity nerves there. But in terms of motor response, it will be responsible basically by the innervation of all of the muscles that are contained within the region of the thinner area of the hand, especially the short abductor of the thumb, and also the opponent muscle of the thumb, and then the superficial flexor muscle in the thumb. So when we think about the medial nerve, we have to think of its function. So one of the main ones, and one of the most important ones in the hand, would be the opposing thumbs. And opposing thumbs is a very exclusive movement of mankind, and animals, remember, don't do that as we humans do. And in terms of cases, well, what can we see in this nerve? So since it is responsible for the thinner muscles there, it is also involved in the atrophy of those muscles. So it is in the second and third fingers, and that's under the responsibility of this medial nerve. So one way of acknowledging this is when you have the fist close, and it's usually towards the root of the thumb there. So this is just a sample of how the lesion happens in the nerve and what it causes in the hand of in a bilateral case here. So you see atrophy there, and you also have the thumb not being able to fully work, and also an inversion of the hand arch there. So when we think about Hansen's, we have to think about functions, right? And many times this patient will show problems, but they will still have a functioning hand. So when you propose to go through surgery, you have to understand how much residual function this hand will have. So one of the most important movements here will be the intrinsic position of this hand, which will be given by the action of the interbone muscles there. So this is a very important muscle because it is responsible for the flexion of the metacarpal region there. So you can perform important movements there for your daily activities. So in terms of the third third most important nerve there, the radial nerve is one of the most important as well, because it is in the radial and ulnar regions there. For the pure lesion there, we see that in the trauma quite a lot, but for Hansen's, I don't see that too much. Well, the radial nerve, it comes from the posterior fascia of the plexus, and it goes around that ulnars there, and then it goes to the elbow. and that's responsible for supination there, and it is responsible for innerving all of the extensor muscles that are actually in the hands and in the fist. So when we think about radial nerve, we have to remember the only exception, that is the longest abductor muscle there. It is innerved by the radial nervous. So all of the extensors will be part of the group that is innerved by the radial nerve. So it is very exclusive for the middle of the hand here, which is different from the medial, but it is very responsible for just a tiny area there. So this is just to show you damage on the medium and radial and ulnar nerves due to Hansen's disease, right? So when you touch that radial nerve, you will see the problem that you can face, because sometimes you have to be very careful with the volume of this arm, and sometimes the volume will be higher, and then I would advise investigating the cutaneous superficial nerve there in the radius nerves in the fist. So due to the complexity of dealing with this touch examination at the lower third of the arm there. So in terms of the lower limb, so you have the sacral plexus there, you have the whole description there that is part of the terminal branches of those nerves, and that's the main, the sciatic nerve that goes from the lumbar region there, and it goes towards the toes there. So for us with Hansen's, we are interested in dealing with this sciatic nerve there, trying to when you have problems with the popliteus branch there, it divides in two sides, right? So you have one going towards the fibular region, deep and superficial fibular region, and then you have the other branch that will go towards the distribution to the medial part of the foot.
Fibular nerve, common one, and here under this part, it distributes in two great stems, the common fibular and the deep one, and the superficial nerve. The fibular deep nerve, it's homologous to the radial nerve because it increases all the tensors that are in the joints of the ankle, and also what does it brings nerves? In the tibial muscle, the long sensors, and also for the fibular muscle, and also it brings nerves to two other nerves on top of the foot, these two that he mentioned, and it ends, the nerve ends in this triangle, giving a sensorial termination. In a lesion in this deep nerve, we will have the loss of the capacity of moving the foot, and this is a result. The second one, distribution from the common peroneal nerve to and the superficial nerve, it is motor, and it distributes basically to innervate the long fibular and the short fibulars, and also it distributes into arms through the foot. We have the medial nerve and intermediate ones. This one responds for the lifting of the foot. The last nerve that we're going to talk about here is the posterior tibial nerve. There's a continuation of the tibial one. In Hansen, considering this follow-up of the tibial nerve being deeply in the leg, it is protected by this muscle mass. And in this segment here, we don't have any kind of changes in Hansen. When it becomes in the surface, when it starts being important for us in terms of Hansen. Here, what happens? It starts here, and it distributes in two other arms, in the medial and the side one, that theoretically would be homologous to medial nerve or ulnar lateral side one. So it innervates all the intrinsic nerves of the foot. The lesion of the tibial posterior nerve causes a foot like this. We will have atrophy, and we would talk about the ulcers also. See the lesions here in the tarso tunnel. It's similar. We have arteries. The tendons are the flexor muscles, and also the tendon, the tibial posterior muscle. It's a very, very mixed area. But I draw the attention to an arm of the posterior tibial nerve that is the nerve. This arm here, I made a study on this. And it's very important. It happens in the flexors, under these tensors. But when this over the tensors, it can not bring a lack of sensitiveness to the patients, and they would have then an ankle ulcer. And finally, the sensitive, very important nerve that we have to assess in the loss of capacity is a sural nerve. It's a formation, is a contribution, direct contribution to the tibial nerve, but it receives also 75% sometimes of a connection anastomosis of this other one. And it responds for the innervation of this part, posterior part of the leg and the side border. But I draw your attention here because check this, there's a chapter in neuroanatomy that is very important, essential one in the electrodiagnosis, that is a question of the connections. I see it connects with anastomosis with the superficial nerve. So we have to be careful in this sensitiveness assessment. It can tell you that it was a subject of my dissertation. It has to do with the connection in the medial nerve of anastomosis of Bertini, or the ones with the radial one. And also these connections, they have a very huge importance when you have a sensitiveness assessment. We have to respect this, not only with the nerves, but with the muscles. How do we touch the nerves? See here in the picture, and remind you that the loss of sensitiveness in the side part of the foot is very important because it can develop ulcers of side borders that are very difficult to be corrected and treated if they're not done an early treatment and an early detection. The anatomical knowledge and functional one allows really to help in the clinical diagnosis, as well as prevention measures and rehab for people with Hansen. Our proposal here was exactly to give just an oversight of this subject. Surely the colleagues that will use this knowledge is that to prevent Hansen, there's no need to have basic knowledge of neuroanatomy because you're also ready to have a good development in the preventive treatment. Surely for surgical rehab, there's a requirement to improve and advance your knowledge, of course. Thank you very much.
Gracias, doctor Jorge.
Thank you, Dr. Jorge.
Okay. No sé si en esta parte
I don't
hay
know.
alguna otra
Is there any other
presentación o ya
presentation
la
or?
Sim, sim.
Yes, yes.
Entonces,
Eu posso falar, doutor Nestor?
Can I
Sí.
É o
speak,
seguinte,
Dr.
nós que cada vez
That
mais esse
more and
conhecimento
more this knowledge, anatomic knowledge, is not being considered. And in fact, it's one of the core importance here for, there's no kind of
outra coisa, simplesmente
we just, it is because if now we're changing the path of the diagnosis, our expertise will reach with community agents, technicians, people that don't have a medical degree, but they have to have this knowledge regarding the anatomy to value their matter neurological, the nerve cannot be forgotten. It was with this idea that we spoke about this. Perhaps there's nothing exclusive about this. When we start talk about prevention capability, we gave an approach about this.
Gracias, doctor. Entonces, no sé si hay otro ponente.
I don't know if there's any other speaker.
O solo es el doctor
No.
Jorge para esta sección.
Oh, only Dr. Jorge for this session. Dr. Estela will speak also about prevention. Dr. Nestor, it's a double dose. Stella and myself were a couple, and our mission, although we're retired already, our mission is exactly to talk about Hansen. We're always traveling in the whole country to talk about our experience and expertise. Thank you very much. Okay, thank you very much, Dr. Jorge, for your excellent presentation. And pass the floor now to Dr. Stella.
Aqui, tem reabilitação. Aqui para frente, isso, você pode... Mas vou deixar aqui você se apresentar primeiro.
Solo una pregunta en términos del
Just a
tiempo.
question regarding time.
Teníamos previsto
We had foreseen for this section.
El tiempo era,
the time
estamos
was,
un poco pasados del
we're
tiempo.
overcoming our time.
No sé cuánto tiempo
I don't
requiere
know
doctora
how
Estela para
long
su
Dr.
sección
Estela
de
needs
presentación.
for her
Em
presentation.
torno de 30 minutos, de
30
25 a
minutes,
30
25 to 30 minutes.
E o doutor Jason também
Dr.
teria mais
Jason
uns
also
30 minutos.
needs
Então, acho
30
que a
minutes
gente...
also.
Por el tiempo y viendo las
Because
preguntas
of
que
time and
están
seeing the
puestas,
questions
hay
that we're
una
receiving,
combinación de
there
preguntas
is a
que
combination of
parecen más
questions
del enfoque
that
también del
seem
doctor Jorge y
more
doctora Estela, pero están
regarding
combinadas por
Dr.
el
Jorge
enfoque
and Estela,
del
but
doctor
they're
Jason.
combined
Quizás
with Dr.
podemos
Jason.
abordar la presentación
Maybe
de
we
la
can
doctora Estela
talk about the
y de
presentation of
inmediato
Dr.
seguir con
Estela and
la
then
del doctor Jason para
Dr. Jason.
cuando estén las
Then
preguntas
when we have the
poder ustedes
questions,
observar
you
cuál
can
tiene
then
un enfoque más
check
de
the
la
one
relación
that
de
has more
trabajo del doctor
relation
Jorge y la doctora Estela
with the
y
questions
cuál
that are being
del
asked
doctor Barreto. Doctora
regarding
Estela,
to
entonces
both.
le agradecemos
So thank you very
25 a
much,
30
Dr.
minutos.
Estela. You had 25 to 30
Importante el
minutes,
tiempo,
please.
es muy corto.
Unfortunately, Unfortunately, the time is very short, but we thank you very much for the time that you're giving us. I pass the floor to you and request you to share your presentation.
Conseguem ver a
Can you
apresentação?
see my presentation?
Sim?
Yes, very well.
Deixa eu ver. Ué, não...
Eu mudo aqui. Não, é o de baixo, né?
Isso.
Tá. Qual que você mudou, Patrícia?
Isso, só uma tela. Isso.
Tá. Bom dia a
Good
todos.
morning to all of you. I thank you very much for the invitation to talk about my experience during 3 decades in the Institute Lauro de Souza Lima, which motivated me to have my master's study in Hansen, where I assess the life quality of the people that were submitted to tendon transference surgeries in hands, feet, and face also. So today, adding to what has already been talked about, neural commitment, we cannot detect any kind of superior and lower limbs in order for the person to have a good life in spite of their limitations. We try to minimize the prevention of disability in Hansen is fundamental. We know very well that reinforcing most of the problems that we have regarding the neural lesions of Hansen, they can be prevented through an early diagnosis and a correct treatment. But the neural commitment can happen even with an early diagnosis and a correct treatment of the disease. Reinforcing also the lesions that can happen in the face. We have here this part that is the disability of closing your eyelids, where this open part in the eyes has to be treated correctly. This can be treated and many times through surgery, where we use the transference of temporal muscle divided in 2 parts in order to have the occlusion of the eyelids. The superior limbs, you have here the 4th and 5th finger grip, the loss of the thumb and the medial nerve, and rarely we also have the fallen hand, the lack of capability of moving your hand because of neural nerve. In the lower limbs, as we saw, we have a lesion of the tibial posterior nerve causing the grip of the fingers, and this is very bad for the gait because a compression when it's very in the distal phalanges that can also bring ulcers, and also the fallen foot where the pressure is concentrated in the anti-foot. It's important to highlight that, as Dr. Jason will speak later on, people, the Hansen treatment has its time, and then it is considered that it's curable. But we know that even after this treatment, people still can be having neuropathies and reactions. And for people, Hansen is not cured while it still is causing disabilities, or as his hand with this patient here that we see on the screen. The patient has been cured for more than 15 years, but the difficulty to hold something because of loss of the thumb and the grip of the hands. So the prevention of disability in Hansen is fundamental, and it's the responsibility of all the health team in all the stages of the disease. It has as an objective to keep the functional capability of the hands, feet, and eyes, and also avoid deformities and greater reduce stigma and recover the self-esteem, among other reasons that we will see during the presentation. Reminding the prevention of disability is not done isolately. All the health professionals, the occupational therapists and nurses, psychologists and social assistants, and also technicians in prostheses have a fundamental role in all of this. So we work in a multifunctional team. The assessment of disability starts with a neurological assessment or monitoring of neural function. We have here in Brazil the forms from the health ministry that are the entrance doors for with the filling in of these forms. It can be done by the physiotherapist, by the doctor, or if you don't have these professionals, also by the nurse. It has the function to help in diagnosis, identify the early signs of neuro commitment, physical disability, and then customized for each patient. As you can see here, we have we can assess the face and the nose, the eyes. Then we have the part of the upper limbs when we will touch the nerves, as Professor George just showed, the muscle force, we will see some specific muscles, and also inspection and assessment of sensitiveness. So we have here a little bit of pain, but here we put a greater force. You can see if here this here on the hand is responsible for radial sensitiveness, and reminding all these points here come from nerves 1, 2, 3, and 4 are the medial nerve, where we with the right and left upper limbs. The same happening with the lower limbs, where we will touch the nerves, assess the muscle force or strength, and also the sensitiveness. And we don't have here only on this part of the foot, but this part here on the upper part of the foot is responsible for sural nerve. And here, number 10, we have here the path is a point where we will check the integrity of the deep part of the fibular nerve. And also the back of the foot is the posterior tibial nerve. Here in this card, usually we use geometries or monofillers of Siemens-Weinstein. It has monofilaments where green is a lighter one, and it corresponds when we have we charge this monofilament in the skin as 0.007 grams. And if the person feels where we are touching, assessing any kind of sensitiveness, it is considered normal for hands or for feet. And then our test ends with this color, because once they feel this, we dye or stain a green color. If they don't feel anything, then we continue with other colors. So if they feel with blue, it's a decreased sensitiveness in the hand, but still in the foot they have it, then we say we will only follow up to see if they continue in blue, or if it improves to green, or it evolves not satisfactory to other colors where monofilaments are heavier. The purple one, monofilament, when it's touched, it is 2 grams. And how do we interpret protective sensibility that is decreased, but still sufficiently to avoid lesions in hands and feet. And continuing, we have the pink one, that this one here, that is thicker, where the touch with the skin is equal to 30 grams of pressure, and the person has this monofilament with a deep sensitiveness, being able to feel pain, not feeling pain. The pressure of this monofilament in a response, we will then have a black color, and the person has a high risk of developing lesions in hands and feet. The touching of the nerves also reinforcing, because you've heard this already, the superior, the upper limbs, here in the elbow, and then tibial posterior nerve in this retromyellar medial region.
Nós vamos iniciar, então, pelo músculo
For the
orbicular dos
muscle
olhos, onde
strength
nós vamos
assessment,
fazer
we
uma
will
pressão
check
no
the
sentido
orbital
da
muscle of the
elevação
eye so
dessa
we can see
pálpebra.
the
E aí vamos ver se ela
elevation of the
tem
palpebra,
uma
so we can
resistência
see
máxima,
whether or not it
mínima
has a
ou
maximum or
média.
minimum
Para os
resistance
membros
or average.
superiores,
So
nós
for the
graduamos
upper
de
limbs,
0
we
a
will
5,
grade that
onde
from
0 é
0 to 5,
paralisia
and
e
0
5 é
is
musculatura
paralysis, and
normal.
5 is
E
normal
aí,
musculature.
aqui podemos ver o
And here
teste
we
do
can
músculo
see the test of
addutor curto do polegar,
the short
inervado
muscle of
pelo
the thumb
mediano. Aqui
being
o
set by
primeiro
the
interósseo
medial muscle.
dorsal,
And here we have
inervado
the
pelo
first
ulnar,
dorsal
e nos
muscle
membros
elevated by the
inferiores,
ulnar
a
muscle, and
musculatura
in the lower
inervada
limbs you
pelo
have the
nervo fibular.
muscle
Então, o
being
extensor do hálux, e
activated
aqui
here by
o músculo tibial
big toe, and
anterior,
you have the
responsável,
tibial
então,
anterior
pela
muscle responsible
dorsiflexão do
for
pé.
dorsiflexion of the foot.
Terminando a nossa
And
avaliação de
by the end
palpação,
of our
sensibilidade e força
assessment for
muscular, nós
sensitivity
vamos
and muscle
determinar o
strength, we
grau de
will
incapacidade
determine the
que
degree
essa
of
pessoa
incapacity that this person
apresenta.
has
Esses
presented.
valores, eles
So
são
these
expressos
values will
de
be
0 a
expressed from
2,
0 to
onde, como
2,
nós podemos ver
where
aqui, o
we
grau
can see
0
here,
é a pessoa não
0
tem
is the
nenhum
case when the
problema
patient has no problem at
relacionado à
all
força
related
muscular
to
e à
muscle
sensibilidade,
strength or
nenhuma
sensitivity,
deformidade visível
nor
em olhos,
visible
mãos e
deformities in
pés.
the eyes, hands,
Já
and feet.
se
So
nós
number one
expressarmos o
will
valor
be
1, a pessoa tem
expressed
diminuição
for
da força
when the patient
muscular
has a
nas
decrease in
pálpebras,
the muscle
nas
strength of the
mãos e
palpebrae
nos
and the
pés,
hands and
mas
the feet,
sem nenhuma
but no
deficiência visível.
visible
E
deformities
também a
or
perda de
limitations.
sensibilidade,
And
ou
also the
seja,
lack
a
of
partir do
sensitivity. So
monofilamento
from the
vermelho
monofilament, from
até
the
o
red
monofilamento
filament to
violeta,
the
não
violet
há
monofilament,
grau de
you have no
incapacidade.
degree
A
of
partir do
incapacity.
vermelho, do
Starting on the
laranja
red
e do
to the
magenta
orange
ou
and then to
preto,
magenta,
a
you will,
pessoa
or
então
of
vai ter
black, you will see
grau 2 de
uh,
incapacidade e
degree 2
também a
of
presença de
incapacity,
deformidades
and then
visíveis, como, por
the
exemplo,
presence
a
of
tripíase,
visible
que os cílios
deformities,
ficam
such as
invertidos, um
trichiasis when you have inversion
lagoftalmo,
of the
quando
cilia,
nós estamos nos referindo aos
lagophthalmus
olhos,
when
e
we
também
talk
nas
about the eyes,
mãos,
and then
a
we in
presença
the
de
hands we also
garras,
have the presence of
reabsorções
curved
ósseas,
fingers
mão
and
caída,
bone reabsorption,
úlceras, tanto em
atrophy in the
mãos como
muscles,
em pés
ulcers,
também. E o
both in the hands
mesmo
and the feet. So the
serve, então,
same
para o
goes
grau de
for
incapacidade.
the
Portanto, o
incapacity
grau
degree. So
2 de incapacidade
degree
nos
2 for
faz
incapacity will
pensar quais
lead us
seriam,
to think
então,
what are the
os planos terapêuticos,
plans for therapy
juntamente com a
that we
equipe,
should
para que essa
apply to
pessoa
this patient so that
diminua
the patient
ou evite problemas
can
maiores,
avoid future
tendo em vista que
problems,
alguma coisa já está
considering that
acontecendo.
something is already taking place there.
Quando nós falamos em prevenção de
When we speak
incapacidade,
about the
nós vamos
prevention of
utilizar técnicas
incapacities, we
simples
are
que
going to
podem
use
ser
very simple
feitas em
techniques
campo.
which can
Não
be
tem
performed on the
necessidade de
field.
um
There is no
local
need
com
to have
muitos recursos.
proper
O que nós temos que
clinic
ter é boa
resource, and
vontade
we just have
e
to have some
orientar os
goodwill of
pacientes a
actually
todos os cuidados que devem
making
ser
it clear to the
realizados. Então,
patient
por
about
exemplo,
the
a hidratação,
care that
a
we have to take and what
lubrificação
they should
e a
do. So
massagem de
hydration,
membros inferiores e
lubrification, and
superiores.
massage of upper and
Orientação
lower
com
limbs,
relação aos
guidance
autocuidados
towards
após a
self-care
avaliação da sensibilidade.
after the assessment
E
of sensitivity, and
exercícios, que
also
nós chamamos também
exercises,
de
which
cinesioterapia,
we will
quando
call
nós avaliarmos
kinesiotherapy.
a força
When
muscular
we
e
assess the muscle
detectarmos
strength,
alguma
we have to
lesão.
also try
A
and detect some
finalidade dos
kind of leisure. So
exercícios
the goal of
é,
those exercises is
basicamente,
to
evitar
basically
contraturas,
avoid
também
contractures
manter ou
and
aumentar
also to
a
keep or increase
amplitude de
the
movimento e
movement
aumentar
amplitude and
ou aumentar essa
or
força muscular
increase
que ele
the
está
amount of
apresentando, seja
muscle
em
strength the
mãos
patient
ou em,
is
ou em
capable of.
pés.
So be that for their
As
hands or the
condutas de
feet.
prevenção de incapacidades
So prevention
simples que nós temos é
conducts
a
for preventing
hidratação das mãos,
incapacities.
que
Very
podem ser
simple. We
feitas
have the
tanto numa
hydration of the
simples
hands that can
bacia
be
com
done
uma
in
água morna,
with just
posteriormente
warm water. It also can be done with hydration using lotions or self-massage. If you have a tank for a proper tank for bubbling there, you can have hydro massage for the hands, and that's an advantage compared to just using a bucket of water, because that presents the option of actually have a hydro massage there, trying to increase the amount of also the using either heat or cold. You can, if you have an edema in the hands, you can also increase the amount of circulation you have using hydromassage. So this is a patient that has used hydration with a cream and also self-massage. So we always tell the patients to do that themselves, because they won't always have a nurse with them. So that's something they have to learn how to do in order to perform at home as well. So the exercises will be prescribed individually according to the assessment for the muscle strength and their limitations. So we have assisted exercises where the therapist will help, or maybe the other hand will help. And we also have active exercises the patient will perform themselves, and some resistance can be applied with a rubber band, for instance, so that they acquire a little bit more of muscle strength. So when they have paralysis, this is a passive exercise. It's just to keep the amplitude of movement. So some exercises will also involve some of the simple resources, such as rounded shapes and stuff like that, that we can use for each patient, depending on the case. And this is for the interosseous musculature. So this is the example of a resistance movement with tension, with the clay there, just to have exercise for the thumbs. For the lower limbs, you have, for the feet, we have to elongate the calcaneus tendon there, because otherwise, if you have surgery, the shortening of this tendon will be a contraindication, for surgery. So extensive exercises for the atlas, for the atellium as well, and also for the intrinsic arch of the foot. Here we have some objects being used, and you can use also flexion of the atellium, so using a towel in folding it with the toes. This is a piece of weight just to strengthen the dorsiflexion of the foot. Very important to consider the orthotics or splints. So here we have a splint that is a very simple one. You can make that at home. These are just rubber bands that are intrinsically substituting the musculature of the hand. So they will keep the hand closed to 90 degrees, and then the person will actively extend the interphalanx musculature. So this one will keep the space, this gap between the thumb and the first finger, the second finger that is, and this will keep the space there, this gap, because that's very important in the posterior phase of the surgery, after the surgery of tendon transplant. So this is for when the patient cannot walk, just for resting at the 90-degree angle there, and the same goes for the other picture there. So if the patient is going to walk by themselves, they need to adapt the shoe with one of the orthotics that we have here. This is a Cordeville spring, we call it. So this is a Cordeville's coil that's in the shoe, so they won't have that movement. They will keep the foot always at 90 degrees. These are other kinds of devices for the feet. So this is the Gary's ferrule there that we can use in the shoe whenever they use sneakers or sandals. Those springs there will keep the foot flexed, so they will play the role of the dorsiflexor of the foot. So sometimes the patient will have some adaptations here. This is the spring that was used, a coil that was used from a car engine, and this is something that is used during gait when you can move the foot normally, right? Because of that support. And so when we speak about prevention of incapacity, it is paramount that we consider the shoes. This is in the workshop of the Souza Lima Institute. We have several kinds of shoes here. They are individualized for each patient and their needs. So we consider the shoe and the inner part of the shoe as well. So this is a patient that we had here, a patient as this that has a deformity here, arthropathy at the foot here. It's not only something that happens with Hansen's disease, but also with articulations also. So we don't have sensitivity there. So what we have here, we have the disorganization of all of the bones at the tarsus here. So the person has to use specific shoes. And this is also the case here. And also for healing of the skin after dealing with ulcers, we have shoes and orthotics for each case, and always considering the foot anatomy that we have to consider that this will support the whole body weight, and we have to understand how the bones will behave and the muscles and also the ligaments and also all of the arches of the foot, the upper arches and the lower arches, so that the shoe could be properly fit. The ideal would be to have a prevention of incapacity in the lower limbs with a device like this one, which is the baropodometry. So this device will actually diagnose both statically and also dynamically the gait in order to understand where those pressure points are concentrated. And then if you have a sensitivity in the foot, that's fine. But if you have the absence of sensitivity in the foot, the shoes should have those inner layers that should be created accordingly so that the patient won't develop localized pressure in the sensitive points of the foot, so that you can avoid ulcers. So with that insole there, you can prevent that. This is for prevention of ulcers whenever you have pressure points in the metatarsal region. So here you can see again, feet like this, when you should prevent incapacity of, in this kind of case here, is that even possible? Yes, it is. Well, if this person walks with no proper shoes, they will probably have to be amputated afterwards, because that will be no lack sensitivity, and that will even damage that limb further. So we have to decrease the amount of damage and also the stigma, because that's also associated to Hansen. So feet like this should use proper shoes. We have here orthotics in the shoe, and sometimes we have to even use orthotics in the upper part of in the lower part of the leg as well, so that you don't have pressure happening in places where it shouldn't happen. Also for the eyes, we have also prevention care for the eyes and the nose. Sometimes you have lesions in the facial nerve, so you might have a cornea anesthetic there, so you should use eye drops, and also the removal of the eyelids. Sometimes they have inversions there. They start scratching it, and it might even remove it afterwards, and then you have creation of ulcers, and if you don't treat that, that might lead to blindness. So also nose, whenever you have alterations in the nose, you should wash it and also take care of the hydration within the nose. As it has been mentioned before, the treatment for the reactions for the kind of neuritis, when you have acute episodes like this, the team, not only the medical team, but also the whole team of healthcare providers, the therapists as well, they should pay attention, because sometimes you might have reactions such as this case here, you have the reaction hand, for instance. So this is an acute episode that is very similar to a hand that was in the rheumatoid arthritis phase, and you have all of the logistic problems. And if you don't have the proper treatment, that might lead to hammer fingers and dislocation of the fingers. And when you have that acute inflammation there, you should immobilize that hand and in the functional position, so that after that period you should try and have as much prevention of sequelae as possible. So the lower limbs should also be immobilized after medication. So for neuritis, the knee is immobilized in around 30 degrees and the foot around 90 degrees, so that the nerve would be in rest position there, and it will also respond better to the inflammatory treatment there. So inflammation treatment. This is for the posterior tibial nerve, so you don't need to mobilize the knee here. For the upper limbs, just arm position like this should be enough to keep the nerve in rest position, so you would limit any kind of sequels that might happen afterwards, because sometimes the neuritis would not present pain, just the thickening of the nerve. After the acute phase, both for when you have or when you don't have reactions, and that might happen to the foot or the hand, after the acute phase, after you don't have any other signals there, you could start kinesiotherapy, exercises that will help prevent further incapacity. So self-care, we also have to guide the patients regarding the face, hand, and feet. And we always ask the patients to look at the mirror, to their nose and eyes. So through the hand inspection and self-inspection and cleaning and hydration, they should be able to detect any problem. So if the shoe is hurting, or if you have any pressure point there, especially for the feet, whenever you have limbs that are easier to see, sometimes the person will have to take the shoes off in order to check whether or not they have any kind of sensitivity there, because sometimes the ulcer won't start as an ulcer itself. So it will start in a region when you have a bubble there being formed, and then it will progress towards being an ulcer. So we have groups for self-care. They are very efficient. They are very valuable work being done in Porto Velho with a nursing team of the Marcelo Candia Hospital. So they have groups there and they practice self-care together, so they learn from each other. And we also have the involvement of family members and friends in discussions about self-care, so that they are incentivized towards self-care practices. It is very important to adapt tools for work. So this is just briefly showing the importance of using mittens. So for domestic work, and also whenever you have wheelchair users, they should also have mittens so they don't have any hand damage. Gloves for that. So fork and knife, you have a thicker fork so that people can better grip that fork, for instance, so that they can use that independently. It's very important to guide the patient towards the use of devices in order to not hurt that point, that specific spot further. So using, for instance, support like this, and be the Canadian type or other types. And psychological and social support is very important. Whenever you have different realities of patients, of course, and in each individual would be different. So the professional, the psychologist, and the social assistant should have a very important role to play as members of the team whenever we talk about prevention of incapacities. Now, for rehabilitation, when we talk about rehab, it involves surgery sometimes, and it is about tendon transfer and neurolysis. So neurolysis have the goal of relieving pain and also preserving function. If it is well made, it can prevent the anesthetics in the sole of the foot, and that can also avoid plantar ulcers. So in most surgeries, you will have posterior fascia here, you will have the person with pain. And most of the times you will have, after surgery, you will have, if you have 10, level 10 pain, that would go from 10 to 5 or sometimes even 0, because you will have a mechanical process sometimes of relieving pain there. So many times this function will also come back together with the sensitivity, so that the strength will be preserved as well. Therefore, preventive and reconstructive surgeries, which is the repairing surgeries will have the function of increasing the function of the hand, foot, and face, improving aesthetic elements, self-esteem, and also preventing secondary damage that might be in those places, reducing stigma and other aspects as well. Here we have a hand that has been operated, and this is the tendon that has been transferred, and that will give back the opposing thumb function to the thumb there. In the case of facial surgeries, we have the pre-operation here, and here you can see the gap that is very troublesome there in the eyelid that is associated to the insensitivity of the cornea. And after this surgery, we have the post-op here with the result. But in order for that to happen, we have to speak about it for a couple of days, because you have physiotherapy before and after the surgery. And we also have the occurrence of, for the hands, we also have the surgery of tendon transfer, correcting the ulnar curving there, and also the loss of the opponents of the thumb, opposing thumb. So here we can see the tendon there being extracted. Usually that would be the superficial tendon from the third finger, and that would be sutured back to the dorsal area of each finger, and that would be giving back the intrinsic position. That is one of the techniques, and the other one would be the transfer for the correction of ulnar grip in the palm of the hand.
Here we can see the tendon on the fourth finger, and it was removed, and here is divided into two strings and is sutured in the base of the thumb, the extensor. And after these procedures, surgical procedures, we have a pre and post surgical preparation. The post and pre preparation is very important, because if not, they're going to use the old-fashioned one. We have a hand lesion with a medial nerve, very difficult to grip the objects, and also with glasses. And then the post-operation, we have the correction of this loss of the thumb, and you can see you have quite a normal movement, and they will have a very normal life with a life quality that they didn't have once they developed the lesion. We can see a correction on the grip with the third and fourth finger, and here aesthetically and functionally much preserved. Here the loss of the thumb, and after the surgery they regain the movement. In the lower limbs, the correction series for feet, fallen feet, or fallen feet, and inverted feet that we call equinovagal. And here one of the surgical surgeries is remove the long tendon and is passed to this part of the foot. So you remove this tendon, and then it passes, it becomes in the top of the foot, so it's more important during the gait to have dorsiflexion. So we have patients with bilateral lesions. Here they had the transference. They had a new transference here. This is another technique. They didn't have the fibular, so they removed the tibial posterior muscle that has the inversion of the foot. And you can see the tendon here already transferred, and they made the inversion of the foot, and now he has a dorsiflexion. And with all the preparation, re-education of this gait, they will be able to buy appropriate shoes and to have a much better life from the functional point of view, aesthetically speaking. And finally, but not less important, is the socioeconomical rehab. This, therefore, the people that had Hansen, they can once again have their role in social life, reminding you that rehab will only be effective if it brings benefits to people with Hansen in all these aspects, physically, emotionally, spiritually, social, and economical. And therefore, the person will have restored their dignity and self-respect. Therefore, health professionals, you are very important. You're important because, therefore, less people will have Hansen in the future. You're important because you know and you have to recognize researching signs and symptoms of the disease that is quite prevalent, and you can contribute with your knowledge in order to eliminate the disease in your country. And the conclusion, when we talk about prevention of disabilities, some words make all the difference. So knowledge, dedication of the professional, unselfishness, empathy, reminded that it's a teamwork, and this team has to have determination of the struggle in order for all these processes have to be considered in the rehab of the patient in a holistic approach. And above all, what do they have to have is love for their work and love for the patient. Thank you.
Muchas gracias, doctora Estela.
Thank you very much, Dr.
Como
Estela.
bien dijo el
As
doctor
was
Jorge,
said by
ha sido
Dr.
una
Jorge,
excelente dupla.
they are an
La
excellent
exposición es
couple.
bastante clara.
They're
Como
very
acordamos,
clear in their
vamos a oír
explanations.
los
As we
aplausos de
agreed,
todos nuestros
we have
colegas en diferentes partes de nuestra
applauses
región.
from all people in
Excelente
different parts of
presentación.
our region. Excellent
Como
presentation.
acordamos, como
And
hay
as
una
we
mezcla de
agreed, as is
preguntas
a
que tienen
mix
mucho
of
que ver
questions
con
that
los
have to do
aspectos abordados
with all
por la
the
doctora Estela y el doctor
subjects
Jorge,
mentioned by
y
Dr.
están
Jorge and
mezclados
Dr.
por la
Estela, and they're
visión
mixed
del doctor
with the
Jason
previous
Barreto.
sessions.
Entonces vamos a
We
de
will
inmediato a pasar a la
now
presentación
immediately
del
go
doctor
to the presentation
Jason.
of Dr.
Y
Jason.
una vez terminada la
And once
presentación,
we
vamos
end,
a
we
seleccionar un
will
grupo de preguntas
select
o
a group
muchas
of questions
para poder
of
hacer
many in order
respuesta en
to
vivo,
have
si nos da el tiempo,
live
porque está
answers if we
bastante
have
corto el
time,
tema.
because we
Doctora
have a
Estela,
very
muchas
short time.
gracias.
Thank you very
Luego
much,
le
Dr.
damos la
Estela.
bienvenida al doctor
Very
Jason
welcome now,
y vamos a
Dr.
abordar
Jason, and we will
otro
talk about
escenario
another
del proceso del
scenario
tratamiento,
of the process of the
en el que
treatment.
lepra tiene, como ven en las preguntas y
As you see
respuestas,
in the
diferentes
questions,
enfoques.
Q&A, there are different
La
approaches,
poliquimioterapia o terapia
polychemistry,
así como el
also
tratamiento de las reacciones
treatment
y,
of
desde luego,
reactions
la
and
prevención y el
the
manejo
prevention
de
and the
estas
management
discapacidades.
of disabilities.
Ya estamos viendo, solo falta
We're
que
seeing,
ya, perfecto.
okay, great.
Doctor
The screen
Jason,
is
ya
okay. Dr.
está
Jason
la
Barreto,
pantalla y
the
vemos su
screen is
presentación
already,
perfectamente. Muchas
and we
gracias, le
can
doy la
see
palabra.
your presentation. Pass the floor to you.
Bom,
Well,
voltando, né, vamos conversar
coming
pouquinho
back,
sobre o
let's
manejo
talk now
terapêutico,
about the
né,
therapeutical
específico
management specifically for
né?
this
A gente já
kind
falou
of
sobre
treatment. We talked about
microbiologia, como o bacilo
microbiology,
penetra,
how the
né?
bacillus
As formas
penetrates,
iniciais,
the
como fazer o
initial
diagnóstico, né?
approaches,
Só
how to have a
recapitulando,
diagnosis,
né?
just to
Térmica dolorosa e tátil, a prova da histamina,
tactile
falou
and
de histopatologia,
histamine
as
and
formas clínicas,
histopathology,
né?
clinical
Quanto
ways
mais
and
tuberculose,
more
mais
tuberculosis,
imunidade
more
celular, quanto mais
immunity in the
bichoviana,
cells,
mais
more
imunidade
visual,
humoral,
more
a
humoral
imunidade celular
immunity,
não
and cell
é
immunity
protetora e a
is
imunidade
protector,
humoral
and
não é
humoral
protetora.
is not a
Então,
protecting. And
você
then
não pode
you
tratar esse
cannot
indivíduo
treat
aqui, que ele vai
this
curar
person
espontaneamente,
here
como
that
esse
be
paciente
cured
aqui, ó, com
spontaneously with this
tuberculose,
patient here
que
with
a
tuberculosis,
tendência dele
that
é
this
piorar
trend
com o
is
tempo, como a
to
gente
worsen,
mostrou a
as
foto
we've
daquela menina,
saw,
né?
we show,
Então, a carga bacilar, quanto mais para cá,
showed
mais
the photo of that
multibacilar,
child.
quanto mais para
So
cá, mais
multibachelor here
falso bacilar.
towards this
Então, só
lower
revendo, né,
bachelor.
os
Just
conceitos,
reviewing everything everything that we've seen already. The tuberculosis patients can be treated with a shorter period, indeterminate also, but the amorphous patients, if they're with a shorter period of time, it's not a little common that they will have a relapse. So these patients, the amorphous, they will have type 1 reaction, that is a located reaction in the skin, and it worsens. Then Bischovian patients, according to Ridley, they will have type 2 reactions, that is erythema, with nodes, PB, BB, bacilloscopy. We cannot have, at the end of the treatment, these globes. We have to have at the end of the treatment fragmented bacillus, very little color. We cannot have any compact or entire bacillus. If we have any proof of these kind of bacillus, we have to send it to a reference lab and research a relapse and also reinfection or resistance to medication, or even insufficiency. Sometimes it's insufficiency. A patient with a very great burden of bacillus is well known for a long time that sometimes they cannot be cured with the 12. There's some very few cases, but there are. And most of them, the greatest amount of them, the patients are able to cure polytherapy if you do what has to be done. That is to control the communicators and also to break the transmission chain. The biopsy, we've seen already here only a detail of the difference between Faraco, that is the correct dye for the Hansen bacillus. You see this in the histology. And when you use ZIO technique, the common one, the bacillus doesn't die or stain. You have to see what is being used in your country. Many countries, they don't use Faraco technique. They use the common ZIO technique, and many times the patient, multibacillar patient, doesn't have any kind of diagnosis. So this is a classification that every reference center should use, but we don't have histopathology in all the places. So we have to remember, the more near the tuberculosis, less bacillus you will find, and more destruction of the nerves, more lesions of the nerves. The more Bischovian, more bacillus you have, and less destruction of the nerves. Destruction generally is of the tendons or of the joints, testicle, eyes, due to the reaction of the reagent. So Hansen bacillus, here what we do in loud inoculation, we used to do in the past, now only in mice, inoculation in mice to see if the bacillus is feasible. Here, the bacilloscopy, as I showed you, serology, that can be done by ELISA or quick test, the criteria of diagnosis. And now we're going to talk about polychemotherapy. Dapsona was the first drug to be introduced, this white pill here. It was introduced in the 40s, and initially Dapsona injectable once a month. Then we had the oral Dapsona. For many years, it was the flagship of the treatment for Hansen. Hansen is very sensitive to this drug. In 1962, we had clofazimine, that is a dye with bacteriostatic action in high dose, even bactericide that can be used also in other mycobacteria. In 1963, in a lot of research, rifamycin and the Hansen bacillus by Dr. Ancolola, and this gave place to what we know today, the polychemotherapy reduction. Clofazimine, pills of 150, and here pills of 300 milligrams, which is the principle of this polychemotherapy. You give a dose 20 times sufficient to eliminate the bacillus. Those bacillus are metabolically still active. They die during 24 hours. And the bacillus that continue, that resist, that don't have metabolically active, adapsona daily or acrospimine will avoid the growth of these bacillus, or even they can even be killed also. Initially, this regime of treatment was of 2 years, and then it passed to 1 year, and now we have a single regime only with this burden here, the MD3-OUNA, one regime only for everybody. A great problem. This pill, the white pill here that I have to be very careful. Sulfone is the first to be discovered, but it has more side effects. It can bring gastritis, so the patient has to be fed before having the pill, always, because another won't tolerate it very frequently. They leave it aside. Hepatitis, also, many the patient that have some using other kind of medication. Hemolysis is hemolysis. Every patient taking the Dapsona brings 0.1 or 1.2 of hemoglobin, but they have enzymatic insufficiency or very high dose. For example, for a child or low nurtured person, they can have a very severe hemolysis, as also they can have hemoglobinemia, that is an oxidation of hemoglobin, and the person cannot connect oxygen to the hemoglobin. So these are conditions, severe hemolysis and hemoglobinemia are very severe if they're not recognized and treated. If the person has any kind of pain in the stomach or any kind of weakness or problems, respiration or breathing problems, they have to stop chemotherapy and go to the health unit and see if they're not having any kind of side effects that are the severe. Photosensibility to sulfur, also they're very common to have photosensibility. Sulfone and pharmacodermia, so we have to ask, they're allergic to sulfur, and they don't use sulfona, use replacement medication, or according to the manual 2018 of WHO, you can use levofloxacin, minocycline, or rofloxacin, or claridomycin. So these information are in the manual 2018 of WHO. Very well explained. Patients with kidney problems, they have to hydrate because Dapsona is eliminated by the liver or the kidneys, and to keep, not to have toxicity, the kidney function has to be good. And lastly, very severe, but it's very rare, but it happens, it could be fatal. I've lost patients with it, agranulocytosis. That is one, as it was a problem of the bone marrow. It happens in the first or second month of the treatment. So they have throat problems or fever or stomach problems. They have to have a blood test to see if they have granulocytosis and to be treated immediately because they have the risk of even dying. Okay, so now clofazimine, it's very well tolerated. It causes skin pigmentation that's temporary. The skin and mucosas are drier, and eventually with some kind of you can use this in any age groups and any genders, patients, male, feminine, patients or people with the kidney or liver problems, clozapamine is very safe antibiotics. It cannot be used in pregnant women, and tetracycline cannot even, or in children under 8 years old, there's quinolona or tetracyclinas. So, rifampicina is the flagship, is a great against bacterial, and the Bacillus multiplies once a month. We use 1 dose per month. You don't have to do this every day because the bacillus doesn't multiply itself every day. They can have some kind of rash that is easily cared with. Toxic hepatitis, I never saw this with a single dose. Thrombocytopenia or dengue-like syndrome with fever and pains, but this also is very, very rare. And GH manifestation, diarrhea, or red urine also. Sometimes they get frightened, but you have to explain to the patient that the urine will become redder when they take this drug. And also, rifampicina can reduce the problems for pregnancy. So use this. And also supervised dose until 7 days after in order not to have pregnancy. Although this is not teratogenic and you don't have problems with be given during pregnancy. And in the case of severe intolerance to medication or resistance to medication, the manual WHO considers other drugs. Ofloxacin, level of fluoxetine can be used, clarithromycin, and riboflavin when we will calculate for each patient.
1.5 milligrams a kilogram for dapsone and clozapamine. So this could create, if you go up too much, it might give the patient some anemic symptoms. The minimum dosage is 1 milligram per kilogram. So this is the daily doses. And the clozapamine will be 1 milligram per kilogram up to 50 milligrams a day. So this is when it's self-administered. So again, the daily dose will be 5 milligrams a kilogram for the maximum of 300 a month. Rifampicin will be a very broad spectrum there. So you go from 10 to 20 milligrams per kilogram and no more than 600 milligrams a month because it's very strong. So how long should I provide that for the treatment? Well, with good evolution of this patient, maximum 6 months. Most patients will be up to 12 months, and only for the patients when you don't have a proper response that you can document clinically in the lab with histopathology, that should go to a reference in order to check whether or not they have resistance, if they have reinfection, and then they will be referenced. And then after you detect why the treatment isn't really working after 12 months, that's when you will say, well, this is a resistance, you have to change the medication, change dosage, and that might be an insufficiency as well. It might also be perhaps a reinfection. So you have to understand that, and if you have an elderly patient, you have to have a full diagnosis, and you shouldn't go towards 24 months for everybody. So now speaking about the reactions, as long as the organism is eliminating the bacillus, so when you have this response mediated by macrophagy and also NK cells and NKP cells, once you have that innate immunity there, you will have a reaction of the adaptable immunity, which is mediated by CD4, transforming that theocytose in an epithelioid cell. So the parasitic cells will be destroyed by the CD8 or CD4 cells. If that is an effective process, the disease tends to be self-limited, especially when you have tuberculoid Hansen's disease. So whenever you have a deficiency in immunity that is expressive, or when you have poor social economical conditions, when they have a great burden of bacilli, so whenever you have that, the bacilla will be multiplying, and the immune response will be always in this same cycle here. You have an increase and a decrease in the conditions and so forth, and the bacillar charge will be increasing slowly. So bacilloscopy should be a criteria for the cure of this patient. If the patient is not reducing bacilloscopy year by year, something is wrong there. So as I said before, each patient, each form of Hansen's disease will have a bacillar charge there. And if you have that for a patient that had one or two crosses there, if you don't have medication, that is not an actual bacilloscopy. So for the next year, let's say you have 3-4 crosses there. It's more likely that 2 years later, this is the correct one instead of the first one. So this is very important to understand. Each one of those forms will have a specific bacilloscopy resulting from that. So it's not about just having the bacilloscopy, and you have to also collect in the same spots and then compare samples in addition to the bacillar viability there. So coming back to the follow-up with the patient, immunity reactions, well, we have more than 50% of the dimorphic patients happening doing that. So more than half of the patients that have nodules will have that as well, and they have that reaction before, during, or after the treatment, after polychemotherapy. So patients that will have immunity towards almost zero, will have an extremely late reaction. So whenever you have that kind of nodule erythema, you will have that reaction after the end of the treatment and after a long time after the treatment. And it's not because they don't feel anything, it's just because they were having a reaction that is going to happen regardless of having the treatment to the end. For type 2 reaction, when you have a separation of the macrophages, so they are full of bacillus. So for type 1, you have also epithelioid cells and also lymphocyte cells, and you can see between the vacuolized macrophagi, or you have a confluence of granuloma and others. And what are the causes for the reactions? So the most accepted cause is the recovery for the immunological response, right? So the bacillus will be multiplying and inhibiting the cellular immunity, and that makes the organism stop reacting. And once you kill the bacillus, you won't have that inhibition anymore in cell immunity, so the patient will come back to normal and he will have a full reaction, as it happens with HIV. So you increase CD4 and then you have a decrease of the general status of the patient. So those reactions could be either a type 1 reaction or a type 2 for Hanseatic Vitruvian patients. So for the patients without treatment, we might have the Lucius phenomenon, which is a vasculopathy, a thrombotic vasculopathy, right? So this happens when the patient will be a Vitruvian patient and didn't undergo treatment. So the lesions that they have when they are treated will be nodules and necrosis. So this is important to differentiate. The Lucius phenomenon will be treated with polychemotherapy, and the nodules will be treated with corticoids and thalidomide. So whenever available. So this is nodule here you can see, and then you have pustula here as well. So this is just like acne or folliculitis. So this happens when you have usually after the end of the 12 doses. How do I know this patient needs treatment in addition to that? I can take medication out and I can see if any kind of Hansenoma will be remaining. So these are not Hansenomas. So these are just lesions that will be out of the reaction. This will vanish after corticoid use. Whenever they are active, they won't vanish after the use of corticoids. The necrotizing nodules here for the hand, they need corticoid in high doses. They have a high prophylactic reaction because they might have a heart attack or any kind of vascular accidents because they will have a procoagulating, systemic procoagulating condition. So the nodules might be showing just like stains or plaques in the skin. They might be localized, and we call that multiform erythema. They are nodules under the skin. So that can be the first manifestation of the disease. Sometimes you will see that with they are confused with urticaria. So how can I know that that just appeared out of blue, this is Hansen's and not leukemia, or that it's not any other kind of infection or vasculopathy or urticaria? So I can either have a biopsy and check for the bacillus and also the Faraco check, the Faraco technique, or maybe a fasciculoscopy of the ear and the skin there. So whenever you have patients like this and they feel pain, they are usually Virchovians. So whenever you collect those samples, be it in the lesion or outside of the lesion, you should have a positive result. So this is a Lucius phenomena. So this is lacerine leprosy. So we start like this, and then it goes to necrosis, full-on necrosis, and then eventually that might be cardiolipine that will be positive there in those cases. So what we find there in the histopathology for those patients when they have Lucius or when they have a reaction to the nodules erythema. So you could see neutrophyli there. Whenever you see those, which are the biggest cell there, those would be osteosus. So when you have a broad cytoplasm, you will see thrombosis there, and it's not uncommon to see thrombosis there. If you don't see neutrophic there and you have no infiltration in the nerve, this is nodules erythema for Hansen. So this is histopathology of this reaction. And in order to confirm this diagnosis, you have to have full coloring of Faraco technique there, and you have to you will show that the bacillus will be fragmented, that because most of the cases will happen in cases with patients that are undergoing treatment already. But they could be, if it is the first manifestation of the disease, that might look a little bit different. Now, changing a little bit more, it could be stains, hypochromic stains in the skin, and that look like mycosis and pityriasis or mycosis, fungoid mycosis. So how can I know that this is a reaction lesion? Because I have the abrupt appearance of those lesions, usually with the lack of. If that happens in the patient without treatment as the first manifestation, what should I look for? I'd have to look for to check whether or not they feel that lesion or not, and then you can decide if that's Hansen's or not. And of course, you have to have a touch examination there for the nerves for all patients, but that might happen also with the patients that are already in treatment or undergoing treatment, and they might have one or two lesions, and then around the 7th or 8th month of treatment, they will have that show up, as a reaction. So all of these areas here are appearing, but it hadn't been seen before due to lack of experience of whoever was examining before. But sometimes you can only find that later when you have a full reaction on the skin.
Aqui menino, né, com várias lesões.
Here we have a boy with several of those hypochromic lesions, multiple acute nodules there and spots. So when it is acute, that is a reaction. If you have no treatment going previously, you have to use polychemotherapy, and you also have to touch the nerves and assess their function. And if you have a loss of function in the nerves, and if you have edema and you have lack of sensitivity, you have to use corticoid and polychemotherapy in order to not have any kind of sequel.
A histopatologia dessas formas reacionais vai mostrar
so histopathology will show skin that is hyperplastic there with granuloma that is multifocal with a trend towards anastomosis of this granuloma. So the presence of giant cells such as Langerhans. So this is an inflammation that happens, and that seems to look like other diseases such as tuberculosis, syphilis. What else? Annular granulomas. It also looks like mycosis, psychoebic mycosis, and leishmaniasis. So these giant cells tend to create that appearance, and it should be differentiated from the other conditions. So how can I do that? How can I understand whether or not this is Hansen's? Well, I have to check by testing the sensitivity of those lesions, which will be lacking sensitivity or having too much sensibility. So usually they lack sensitivity. The more it gets to the tuberculoid form, the less you will see the bacillus in the lesion, but you'll see that more in the nerves. So this is something that happens sometimes. The patient will abruptly have this kind of reaction. Sometimes you have antibiotics being administered to this patient with a diagnosis or maybe a vaccine, and sometimes they have some kind of thrombotic compensation, and they should have lesions that would be more visible afterwards, and that is a type 1 reaction before we start treatment. So what should I do in this case? Well, they have several lesions there, right? So they are a multibacillum patient, so I have to treat it as such. And I don't need to have bacilloscopy in this patient in order to understand that I have to go for a year of treatment, because sometimes I have very diffuse lesions there. So even if that patient has those lesions from before treatment, or if they only have that after the start of the treatment, this is already there, but you couldn't see that before because they were not clinically visible at the moment of diagnosis. So this is a type 1 reaction as well. And this is another patient. This is a patient that was in the 12th dose. So this, you could see that before we had small lesions there that would become in the future some leproma. So the most visible one here would be at the shoulders, and then at the upper arms, and then at the abdomen. So one here, one there, and another one there. So according to this classification, this patient would be bulkibacillar. So, but you know, if you see that in detail, you will see that they had small lesions here at the dorsal area, and during reaction at the arms, they became very much visible. So it wasn't the case that they only had these ones that were visible, and these and this and this one, which is the same as the upper picture there. So the one at the upper picture is foveolar, is not well defined, but it is already dimorphic lesion. So the patient should be already with the disease disseminated, but you could not be seeing that. That would be the case, and sometimes they will only be visible when you have a reaction. So if you have a type 1 reaction, that will look like that. So if you have several reactions, that patient had that from before, but you didn't see that. So they're just becoming visible. Same goes here. This is a kind of reaction that sometimes you have peeling out of the skin, and it looks like dermatitis and psoriasis. It would be a type 1 reaction that was many years after treatment. So they had 5 crosses here for Bacillus at the moment of reaction. And he was treated 9 years ago. So for how long can I admit that this patient would have positive bacilloscopy? So for each cross of this, we will add 1 year after the treatment ends. So 1 year after finishing treatment for a patient that is Vischovian, I will have 5 crosses of that bacillus. And then 2 years later, I'll have 4, 3 years, 3, and so forth and so on. And after each year, I will subtract 1 cross of those bacillus counts. So they won't ever not have that positive due to 1 or 3 years, right? Depending on the charge of the bacillus that they had before, they would take long years after treatment in order to zero that out. So they shouldn't have a bacilloscopy that would be in the higher levels or the presence of globias and also the living bacillus. So if they have that, we have to research again about the resistance, infection, or even therapeutic failure. Here, the same goes. If the patient, doesn't really matter if this patient has a type 1 reaction during or after treatment. If they have type 1 before the treatment, they are dimorphic, so they have partial immunity. Partial immunity will have a 12-month long treatment. These are different patients. So a very similar situation, but this on the left, you have lesions that came out after starting treatment, and on the right-hand side, you have one that started before treatment. So both should be treated likewise. So they should have immunochem and then the bacillar reaction. The type 1 reaction will show in epithelioid lymphocyte cells and gigantic cells as well. Usually, the destruction of the nerves, the peripheral nerves and the skin nerves will be very intense. So it is very common to see those as less prone to pain when they are more acute. So how can I diagnose that quickly? Well, that is a reaction of type 1 due to the appearance of the abrupt lesions and also to the reduction of sensitivity in these lesions, while the nodulous one would be increasing sensitivity. So they hurt a lot. And for the reaction, the type 1 reaction, they are hypoanesthetic.
Also must be happening in the nerves that Dr. Josh and Dr. Stella showed you. The facial nerve, the medium. So you have to have a systemic assessment in order to know that the patient is losing their functions. They will start using corticoids in order for them to not to have after effects. So bacilloscopy of these lesions is positive normally, and sometimes at the beginning it's negative, but in the lesions they usually are positive. Of course, if the patient is already under treatment, the bacillus will be fragmented bacillus. If the patient is not treated, you can find fragmented bacillus and also the full ones. But if they still have full bacillus, this is a nerve arm with a live bacillus. This is a patient with active disease. This bacillus will not die because of the reaction. You have to treat and kill this bacillus, and then the immunological system will eliminate through the response granulomatrosis or reaction, eliminate the dead bacillus. The full bacillus, the reaction response will not be able to cure. So eventually, a tuberculoid patient can have an abscess here, as we see, of the nerve. Here's the saphenna, probably, I think, or here, a medium abscess is coming out here. So sometimes the reaction is seen under the form of a nerve abscess, is a necrosis of the nerve, a very severe stage that you have to operate. This is a surgical indication. It's not only corticoids. Here I put medium. Yes, here is medium. And I think here is internal saphenum. It's not sural.
Boa pergunta.
Medial aqui.
Essa feno, né? Tá.
It's the saphenum.
Vamos lá. E
Okay,
durante
so
essa,
during
e
this,
durante é um dos safenos, safeno interno.
it's one of the internal saphenum. I don't know
Sural é
which
safeno
one.
externo.
Sural, the external one.
Aqui, ó, faz uma reação
Here we have granulomatosis reaction with caseous necrosis and the dermal nerve that imitates a lot skin tuberculosis.
Então, quanto
So,
tempo dura?
how long does it last? More than 50% of the patients followed during 6 years, it can have a degree of reaction, can have before or after the PQG. It can be the first manifestation that is in 20%, 80% happens during the treatment. It's from 4 to 6 months the reaction of the erythema and ENH. It could be nose, plaques, necrosis, ulcers during 3 or 4 weeks. And the Lucifer phenomenon before the beginning of the treatment, as I mentioned, which is average time between the beginning of PQ2 and the first reaction. The MHDT with negative bacilloscopy, in the biopsy between 2 or 3 crosses the bacillus, they have a reaction on the 8th month of the treatment. If they're treated with falsi, is after the end of the treatment of falsi. It's the PB with reaction. PB with reaction, AB tuberculoid bimorpho that has a positive bacilloscopy in the nerve, but sometimes it's classified wrongly as falciparum. The one that has a reaction near the last time period, you want to sometimes increase the time of indication. You will have the 24 dose, and then you will have a treatment of the relapse. The AMHDV, the patient that have various plaques, and the polychemotherapy, and they have a reaction. The early relapse, because you stopped the treatment, no, that's not true. What happened is that reaction was going to happen even if you didn't have, if they continue the treatment. And MHV, it ends 12 doses. You spend about 2 or 3 months, and they have erythema. So it's not an early relapse. A relapse is never early. A relapse is very late. A real relapse, because a bacillus, the bacillus multiplication is very slow. You can have a therapeutic lack or resistance or reinfection when these conditions are related to not compliant treatment. Many times there are only reactions. For each cross of bacillus, you expect 1 year of reaction. So 6 crosses, 6 years with reaction. 5 crosses, 5 years with reaction. Of course, the first reactions will be more severe because the burden of the bacillus is quite higher. The last reactions will be more located and much less intense. Okay? So the reactions, back in A here, which are the clinical findings. The reactions to PQT generally happen in the first 4 months of the treatment. So, methemoglobinemia, kidney complication, problems with the liver, granulocytosis, during the 4 first months of the treatment. The reactions to the dead bacillus happen after the 6 months in general. It can happen even before, but it's not common. In the type 1, you have neuritis, edema of the limbs, skin lesions, that is common. And type 2 reaction, you have systemic symptoms, fever, and many kinds of problems with the kidney. And they don't have many nerve damages, but the symptoms of the patients that are very intoxicated and committed systemically and in eyes and testicles and joints. In the lucid phenomenon, what we see is the phenomenon of the progressive skin necrosis. So how can we deal with this? We can find a say, are they exposed to anybody sick also with a reaction? Is it really a relapse? An early relapse? I would say it's not early. It's generally 7 years. Actually, it can be another treatment. How can we know that the patient is not cured? I remove them from the reaction. I see if they still have infiltrate reactions through a biopsy or whatever didn't use of corticoids or thalidomide. I try to find infections, sinusitis, urinary infections, bad teeth, parasitosis, metabolic alterations, diabetes, hypothyroidism, pregnancy, and even stress, psychological stress can cause a reaction. In the ENH, we're going to check the eyes, testicle, joints, and the nerve, besides the skin, of course. Always it's visible. What do we use? We use corticoids. Always checking the nerve function. If we have a reaction in the skin, check if this reaction is not in the nerve. Frequently, it is in the skin and the nerve, because what is happening in the nerve endings of the skin must be happening also in the peripheral nerve. It's always important to check the nerve function, even if they don't complain about pain. So sometimes there's a loss of the neurological function without pain. We'll call it a silent neuritis. We don't have to treat the pain in the nerves with prednisone or thalidomide. We have to check and to treat them with neuroleptic. The function of the nerves, yes, I will use corticoids to decrease the inflammation. And when do we use thalidomide? We know that not all the countries have it. Thalidomide has to be used in men people that don't have the uterus, because we cannot X, Y, I can use thalidomide unless they don't have sexual protective relationship, because thalidomide that is in the sperm also has the risk of passing to this. When do we use people with so we cannot use, and we cannot have any doubt in using this in pregnant women. If we have doubts about using thalidomide with pregnant women, we don't use it. We don't give thalidomide to these women. Hypertense, we can dexamethasone in the dose 1.5 milligrams for every 10 kilos. Dexamethasone don't have sodium. Diabetes patient, I give insulin. I control the diabetes. I try and find other causes, and then I will start the corticoids. For all that are using corticoids, I have to give 400 milligrams of benazole for 5 days to avoid the risk of giardias. Be careful with fertile age group if they're not pregnant, because it can be the cause of the reaction. I get a lot of calcium with vitamin D for people that are using corticoids to avoid osteoporosis. So to research any metabolic reactions and review the context. Yesterday I had a patient that didn't stop having reactions. The mother was a visual one that had never been examined. and we diagnosed it
Então, às vezes, é o
yesterday.
quê?
So
Paciente que
sometimes
está o
it's a
tempo todo em
patient is all
contato
the
com
time in
novos
contact
tipos de
with new and
bacilo,
also
tá?
stimulating the reaction.
Fenômeno de
And
Lúcio, né? Oi,
Lucy,
já estou terminando.
Ok.
Ó, mais um, tá, já. O fenômeno de Lúcio, eu
Lucy
uso
phenomenon,
PQT,
PQT,
heparina e
heparine,
varfarina,
warfarin,
eventualmente, e
eventually,
neurolise para abscessos de
neuralized
nervo,
nerve
tá? E a
abscess here.
indicação é cirúrgica,
Indication
não adianta
surgical,
fazer só
no
corticoide
way
nesses
to have only
casos, tá?
corticoids in
A
these
indicação é
cases.
cirúrgica.
Indication
E
is
lembrar dos
surgical,
nervos
and
superficiais.
remember the
Hanseníase é
superficial
uma doença
nerves,
de
and
nervo, não é uma
Hansen is
doença
a nerve
de
disease.
pele. Então,
It's not
a
a skin
pele tem
disease. The
comprometimento,
skin
mas o
is
nervo
committed,
sempre está
but the nerve is
envolvido.
always
Olha, um
involved.
tibialzão aqui,
The tibial nerve
monstruoso,
here,
né? Paciente
very
tem
huge one.
hanseníase. Esse é um paciente
It's
lá
a
da
Hansen
guia. Isso é
piano.
diagnóstico, né? A gente fazia
This is the
tratamento do nervo desse tamanho.
diagnosis.
Isso é hanseníase. E
And
sempre
also the
fazer
patients
corticoide para
treatment
evitar
to avoid that they
durante o tratamento, né?
get worse
E não fiquem com
and
as
not
sequelas, como
have
aconteceu
these
aqui, tratada com baixa
reaction
dose usada e não
dose
tem
of
fazer
and you
provavelmente
cannot
sem
do
função,
anything else with
tá?
this hand
Então,
without any kind
corticoide a
of
gente usa
function.
os
The
imunossupressores,
corticoids you
uma
use
atomida a
dose
gente só
1 or 2
usa,
milligrams per
né,
kilo totality, but
cometimento
if
de
we have a
nervo,
commitment of the nerves, it
olho, tá?
gets
E para dor
okay.
neuropática,
And
eu
for
utilizo
neuropathic
triciclo em
pain,
dose
use
baixa,
tricyclo in low
associado ou
dose
não a
together
inibidor
or
de
not with
mutação de serotonina.
serotonin.
Anticonvulsivante pode ser utilizado
Anticonvulsant can be
conjuntamente,
used
ou
together also.
fenodiazínico, né, ansiolítico.
Phenodiazinic,
Gabapentina para quem não puder
gabapentina
utilizar
for
nenhum
those
desses
cannot use
aqui.
any of the others.
Anti-inflamatório não hormonal ou opioide
Anti-inflammation,
se tiver neurite.
opioid if you have
Corticoide se
neuritis,
tiver neurite
corticoids if you
também.
have
E
neuritis, if you nerve
e prevenção
abscess,
de
and
incapacidade,
prevention of disease.
todos os
Examine
contatos,
all
uma
the
vez por ano,
contacts
com
once a year
todas as pessoas,
and examine
tá?
all the people.
Aqui os meus
And here to
9
my
professores,
our
Dr.
professors,
Raul,
Dr.
nos
Pramola,
ensinaram a todos
have taught
aqui
us
que nós
all
sabemos e
what we
transformado no
know,
aluno que é hoje.
and the
Eu
institution
passei
is
pouco
today.
tempo.
Thank you very much. I think I overcame my
Tá?
time.
Tá. Ah, então tá bom.
Muchas
Vamos lá.
gracias,
Okay.
doctor.
Thank you,
Vamos ahora
doctor.
con
Now we will go to, we have to
de preguntas,
check
pero
so many
le
questions,
agradezco,
but I
doctor
thank you very
Jason
much, Dr. Jason,
doctor,
Dr.
la doctora,
Jorge, and
si
Dr.
pueden,
answer to
sí.
these questions. Yes,
Voy a
I'm going to
empezar con unas
start
preguntas.
with some questions.
En cuenta que tenemos muy poco
Since
tiempo
we
y
have very
muchas
little time, but
preguntas,
very
podemos
interested
responder en el tiempo
as
que nos
one of
queda
them
y lo
in
que
the
no
time
se
that's left,
responda,
and the ones that are not
todas las
answered,
preguntas podemos
and all the
ponerlas en
questions
Word,
we can put in
responderlas y mandarlas a todos los participantes
a
y
Word
así
and put
nadie se
them
quede
and,
con la duda
and everybody,
que ha
all the
puesto él. Muchas
participants
gracias
can
por
have
toda
their
la
answers.
Adelante, Néstor. Gracias.
Gracias.
Okay.
La primera pregunta es,
The first
¿es
question,
recomendable que ante
is it
cualquier
recommendable
diagnóstico de
that with any
lepra,
kind of
aunque no tenga compromisos
leprosy
del tronco
diagnosis,
nervioso,
although there's no
ya se
kind of
haga
commitment
una
of the nerves,
consulta con
we have a
fisioterapia
consultation with a
o no
physiotherapist
para
or
conocer
not
el estado
in order
basal
to
de
know
esos nervios?
the state of the nerves?
Bom, a característica da hanseníase é ter
The
comprometimento
Hansen
ou da
characteristic is to
terminação
have
nervosa cutânea
a
superficial
superficial ending of the nerves and or nervous
Então, assim, uma
polypherical
hanseníase que não tem
stem. So
comprometimento
a Hansen that doesn't
nem da
have any
terminação
coming
nervosa
of the
superficial, que vai se
nerve
exteriorizar
superficial
sob a forma
endings,
de uma diminuição de sensibilidade na
that you have a
área,
less
né? E
sensitivity in
nem
an
e
area,
também não tem
and also
nenhum tronco
doesn't have
nervoso,
any
o
kind of
diagnóstico
a
de
nervous
hanseníase
stem, the
parece
diagnosis of
pouco
Hansen seems
provável.
to be little
Posso
probable.
complementar?
Can I add, even if you have a diagnosis or not, the sensitive motor assessment is relatively simple if you know how to do it, and it doesn't take more than 20 minutes or half an hour. So it's advisable that during all the treatment to have a follow-up if the patient came for adaptation, is advisable to go so sensitive motor assessments. You have subsidies many times for the diagnosis, the treatment, increase or decrease of the dose. So I think that it's worthwhile always to have a follow-up of the assessment functions, any kind of nerve commitment.
Pode ser não no momento, está certo, mas
He's correct, but to follow up for at least 6 months and then yearly at least during 5 years, if it is Hansen's. Another question, exactly. Why the nerve is completely damaged? These are two questions. The patient
de capacidades. Aqui no LEP, por exemplo,
years of rehab is nerve doesn't have more function in the nerve, but broad damage to a hand ingredient. The thumb falling nerve is over. It doesn't. So the after effects feasible, as Dr. Paul Brain in the 40s, he used to orthopedics, and he adapted them for people with the Hansen. So adaptation is always to minimize these effects, these after effects, but the surgeries is you have to have a hospital and social assistance, physiotherapists, as I mentioned. Surgery, when they're released by the physiotherapy, they prepare all the muscles, they prepare the joints, because that foot that didn't have a function.
In the case of have the thickening of the nerve with no would you recommend the thickness? So that should be accompanied by the reduction of sensitivity, and that is whole territory or some islands, as we say, the islands of areas where you don't have sensitivity. So just the thickening wouldn't be a criteria. So nodules and pain associated to the reduction of sensitivity, pain sensitivity, or even tactile sensitivity, where just the thickening is not a criterion. So if you don't have that, what you can do is go for an ultrasound or through neuromyography. So that's how you would check whether you have a decrease. If that's the case, it's likely to be Hansen's disease. Thickening with inflammation. So checking all of the other possibilities, because the biopsy in a nerve, if it is a mixed nerve, you will have after effects for the patient. So we usually take a biopsy out of just or maybe a branch in the sural nerve. So that would be when you section them, you will have just a small numbness to do more than that. Asylum. But it's reckoning with no decrease in sensitivity at that region.
Ok, siguiente pregunta. ¿Con qué
And now the following
frecuencia
question.
ven anemia hemolítica con
Do we
dapsona en
see
pacientes?
anemia of
Normal previamente al médico se relaciona más esta situación.
often, but
A dapsona é a responsável pelos problemas.
be responsible for most of the problems, more than 90% would be due to a dapsona, can be causer of the anemic, that is depending on the dose, so the higher the weight, right? So regardless of having enzymatic alterations, that might be an hemolysis that is toxicity of dapsone. So it would be linked to the surface of the hemastia, and that would be hijacked by it to the liver. So the other thing would be that the 5% of the anemia cases to be compromised would be the NADPH reductase, which would be then of the anemic cases for enzymatic anemia. So in normal levels, it doesn't really mean that the patient necessarily won't have a severe hemolytic anemia. So here we only have 5% of the cases, so we don't examine for that because of that. So usually they will have dizziness or weakening of their legs, and if they have stomach pain, they will interrupt medication and they come in order to receive treatment. That might be just the use of the hydration, complex B or acidic folic acid, and even a blood transfusion. But it's very rare that they need to get to the level of blood transfusion.
Gracias. Y vamos por la última
Thank you.
pregunta.
Now for the last question.
No
Unfortunately, we don't have more time.
¿Cómo es el tratamiento
I will translate that. How is the treatment for a patient that is a new patient just that has been treated for tuberculosis before? So it's not clear that I don't know if they mean if the patient has been treated previously or if they are still undergoing treatment for tuberculosis. So, well, let's consider both cases. They have been treated and they finished treatment for tuberculosis, or they are still undergoing treatment for tuberculosis. So, okay, so we have to separate. If they have TB, they will have we have to check because they might have tuberculosis or Hansen's, because for when the secretion of the throat could have bacillus, so they might be mistaken for tuberculosis sometimes. I've seen some cases like that. So if the patient doesn't have a clinical case of tuberculosis and they have a positive BIR presence in their spit, they likely have only Vischovian Hansen's, and they have a positive for bacillus in their spit, right? So if they have a ganglionary case or a pulmonary case of tuberculosis, or if they are getting getting too thin and they are losing weight, they are likely to have tuberculosis. And that's what we do is to treat tuberculosis. We don't need to provide the monthly dose of rifampicin, so you just need clofazimine and adapsone. And then we just add those two. Rifampicin would be unnecessary in that case. The rest follows us normally, so we treat both at the same time. If they have been treated already for tuberculosis, they will take normal treatment for Hansen's as normal. Nothing changes. Nothing changes with the three medications as normal. And if they have both, if we confirm that they have both, they will only add dapsone and clofazimine to have the three, and they will to have the two of them, and they will reduce the monthly dose of rifampicin because they have that late daily. Well, okay, we still have a huge amount of questions still pending here, but we don't have much time left. So I think it was a success, this webinar. You know, we had the full participation. We fully appreciate that, and I hope we have the words of Dr. Ana Lucianes so that she can finish our seminar here. And on my part here, thank you very much to the colleagues of the Laura de Souza Lima Institute for your support. We really appreciate that. Dr. Ana, you have the floor. Thank you, Nestor. It's a pleasure to say congratulations and thank you so very much for your presence here. And thank you for being here, you know, Jason, Jorge, and Stella, and also Dr. Patricia, the director of the collaboration, so for the Laura de Souza Lima Institute. Thank you for your support. She is, Patricia is responsible for most of this, and we have more than 600 people connected here the whole time, and it's very important to be able to diagnose and treat that disease in a timely manner because we have other problems going as well. And since, well, we had 4 hours of a webinar here, and people said, well, are you crazy? You have 4 hours with no breaks and that's it. It's not enough time for us to discuss everything that we wanted to. So we have several countries represented here, and we will follow with more to come because we will have space for any solicitation that you have, any questions. If you have anything, you can get in touch with us for any kind of information that you want to get more. I've learned a lot today, and well, the idea is to actually keep on supporting you and your countries and your organizations in order to strengthen your diagnosis capacities and also for treatment. And also to make a network effort here to get in touch with everybody else. So since we have no time to answer all the questions here, thank you very much for the collaboration. Thank you to the Mauro de Souza Lima Institute, and we will work on the responses to the other questions, and we will forward them to you all. And we are available for any query that you have. So thank you very much for listening. Thank you for your presence, and well, we will keep in touch.
Buenas tardes.
Bye-bye.
Después de 4 horas sin ir al baño y sin un cafetito, creo que todos merecen, sobre todo ustedes, ir a comer y a tomar algo. Entonces, un abrazo y...
No breaks, and we deserve a rest now. Thank you. See you next time. Thank you.
Obrigada.